Good morning. I'm Margot Katz, Chief of the Perinatal Substance Use Program at the Rhode Island Department of Health and the State Chair of the Perinatal Substance Use Task Force. There I am. Now, thank you to Brian, Tanya, Arlo, Naya, Ray, and Sidra. My thanks are profound because this conference would not have happened without their help. They really kept me sane this year. I especially want to thank EOHHS and BHDDH who fund perinatal substance use work in the state, and an extra shout out to BHDDH, Linda and Obed, who provided gift cards for our raffle at the end of the conference, provided my boss can find them in my desk drawer at RIDOH and brings them over before the end of the conference. There really are no words for what we as a state and a nation and the world are enduring. I know that I'm struggling with the events of the past few days. These are trying times and difficult circumstances. So I want you to know how much I really appreciate you being here, either in person or online. Our presenters today come to their work with courage, intellectuality, and humanity. And I hope that you will come away from this conference with a new perspective and new ways of approaching your work with this population. This year, my colleagues and I have traveled from Portland, Oregon to St. Louis, Missouri to Washington, D.C. to share the innovative work happening here in this little laboratory called Rhode Island. We have highlighted our purposeful work in drug user health, maternal child health, and harm, street medicine, street outreach, perinatal peer services, and family visiting. We've presented on our RIDOH DCYF collaboration to keep mothers and babies together, and our public health community partnership to tackle congenital syphilis. I am really, really proud of the work that we've done and that we're doing. But it's not all sunshine and unicorns. Let's be honest, human beings and their systems are imperfect and sometimes harmful. But with that in mind, you got to stand for something. The Perinatal Substance Use Task Force believes that pregnant and postpartum people who use substances should not be judged, shamed, disparaged, or disregarded. They deserve to be treated with respect, dignity, and compassion. They are entitled to fair, equitable, and just access to bias-free care. I applaud you all individually and collectively for being here and for your desire to learn, to relearn, grow, examine, and reflect. I encourage you to embrace ambivalence, question authority, and elevate goodness. Now, I saw him come in. Where's Dr. Larkin? Oh, please join me. Hold on, he's got a slide too. Everybody has a slide. Oh, I forgot that slide. That's not you. This is you. Okay. Please join me in welcoming the Director of the Rhode Island Department of Health, Dr. Jerry Larkin. Thanks.
Congratulations, Margot. Thank you. So yes, I start my day with a challenge for Margot, which is arriving at exactly the time that she wants me to go on. So thank you for coming here. I've managed to be in traffic going west, going south, and going north. So I'm looking forward to being in traffic going east later on. So in Rhode Island, actually, one last comment. Margot said, you have to stand for something. And it reminds me of the famous line from Hamilton. Excuse me, you have to stand for something or fall for anything. And I can't think of a time in our history when that has been more true. And in Rhode Island, we stand for taking care of people. That includes our recent development of a mobile crisis response unit for families, 24/7, 365 days a year for our certified community behavioral health centers for the 988. And for many years now, the perinatal substance use program that Margot has led. And we've worked with intention to build a public health system that supports the well-being and dignity of pregnant and parenting people who use substances, as well as individuals in recovery. And we know that this has to be grounded in compassion and a person-centered care, because when we do that, maternal and infant and family outcomes really greatly improve. So I want to echo Margot's deep gratitude for our community partners who make all the work possible, especially the peer recovery coaches, harm reduction organizations, and healthcare professionals dedicated to this work. So, I get propped up here several times a year to talk about the work. You guys actually do the work. So our state's recognition as a national leader in this field is a direct result of all of these strong relationships and partnerships and the work that you do. And while we've made progress, we also know that the work is far from finished in all of our areas of public health, and that today's perinatal substance use conference is a reminder that our shared commitment and our responsibility must continue. So even in these extremely challenging times for public health in Rhode Island and across the nation, we remain committed to ensuring that every infant, child, and mother, parent, and family receives the equitable, judgment-free care that they need to thrive. So together we can continue to build the strong, compassionate systems that support Rhode Island families now and for generations to come. Thank you.
Thank you, Dr. Larkin. Now, can I get the director of the Governor's Overdose Prevention Task Force, my dear friend Kathy Schultz, to say a few words?
That's a great picture of me. It was a few years ago and it was at a and I haven't taken a new picture I want to share with everybody because I like that one. I actually my comms folks said, "Hey, do you have another picture?" I said, "No, I like that one." So, yeah, age it comes, right? So, my name is Kathy Schultz. I'm the director of the Governor's Overdose Task Force. I like to tell when I get nervous. I'm actually not nervous in this space. Sometimes I am. This time I'm not. Being led by an amazing, amazing person, Margot, in this work. She always says, "Stop saying that," but it's true. We went to Brooklyn together. We're due for another Brooklyn visit. But we did an action lab together. And Margot is absolutely amazing. And all of the people that Margot mentioned, and I don't want to miss anybody's name, that make this happen each year, year over year. The amazing work and the innovation of continuing to serve Rhode Islanders, to serve people that are probably some of the most marginalized, living with shame and guilt, which is not necessary and should not be, but it is. As a person in recovery, as a person who has children, I know what that's like to go into the OBGYN or go into the hospital pregnant, right? In recovery, not using drugs even, and still being treated differently. So this work and everything and everybody in this room right now, whether it be that you're just coming here for the first time and just hearing about this work, the perinatal substance use work, supporting parents, supporting the children, supporting the families to navigate a system that is difficult, And I think that the theme today is really, we're in really heavy, heavy, heavy times in many different ways, from the tragedy that just happened over the weekend to the last few months of public health being questioned, right? Which is ridiculous because it's science and it's evidence. But the reality is that we're all here for a common purpose. Some of us are here to learn. Some of us are here because we have lived experience and we've been impacted by the system. Some of us are here because this is just our job and we are here, but you're gonna learn something no matter what. But I think that I said this last year, and I don't remember exactly what I said. I think I was more inspirational last year. It's heavy now. Um, I think that the most important thing that I can say to everybody here is that we are all human and we need to treat each other that way, no matter what. No matter what the circumstances are, we don't always know what somebody's going through. And those attitudes that you may think are negative or those attitudes that you may think are defensive are for a reason. Because somebody was impacted in some way in the system along the way, and that's how we react. Um, I always like to tell stories. I can tell you, I mentioned it a little bit earlier. I had a child in recovery. And I have the best OBGYN. I won't say his name. I'd love to give him a shout out though. He's been my doctor since I was 16. He delivered both my children and he never judged me. The doctor on call came in the middle of the night and she checked me. I'm a person who lives with, well, I'm cured, but I had hepatitis C. And through my birth, through the pregnancy, I did. And she came in and she was afraid to touch me. She woke me up after I hadn't slept in 3 days, rolled me over, wouldn't touch me, and all she cared about was the fact that I had hepatitis C. That was terrible. One of the worst experiences I've ever had in the healthcare system. I was better off when I was actively using and being treated because it was what it was. But being in recovery and being treated that way was very, very difficult. And it was only because I had a doctor who came in when he was discharging me and gave me a big hug and said it's going to be okay that I was able to get over that and kind of move on. But I stand here today to say to all of you, please work together, learn, treat people with dignity and respect, no matter where they come from, because you never know what the story is behind it. And that's it. Thank you.
Outstanding. Thank you. We're all cousins, right? So I'm going to hand things over now for most of the rest of the conference, if I'm fortunate, maybe not all, to Arlo Narva. The Perinatal Substance Use Task Force is very fortunate to have Arlo as our community chair. Arlo has good ideas and vision and grace and kindness, tenacity, and mindful ferocity. And all these things carry us forward to improve the health and well-being of people and families affected by perinatal substance use. So, Arlo, the show is yours for now.
Hi, everyone. Good morning. Like Margot said, I'm Arlo Narva. I'm the community chair of the Rhode Island Perinatal Substance Use Task Force. I'm so honored to be here with all of you. And I want to echo what Dr. Larkin and Margot and Kathy said. We are here today amidst, our grief and our rage and our fear. And I'm just really grateful that each and every one of you in person and over Zoom are here today. Just a little about me and what brings me here. I have been working with pregnant and postpartum people and parents who use drugs for over a decade. Before I moved here 3 years ago, I started a doula program at the Philadelphia Department of Public Health that supports pregnant and postpartum people who use drugs and provides support postpartum for up to a year. And this was due to the high rates of fatal and non-fatal overdose that happen for folks commonly around the 6-month postpartum mark, which is a phenomenon that is common throughout this country, including right here in Rhode Island. Currently, for a few more days, the rest of this week, I serve as Director of Community Health at Project Weber Renew, Rhode Island's largest harm reduction and recovery organization, and the home to the country's first state-sanctioned overdose prevention center, which opened in January of this year. But regardless of any role I hold, I come to this work first and foremost as a doula. Looking at my doula table over there. That is my orientation and so much of why I'm also a harm reductionist. Both doula work and harm reduction honor bodily autonomy, evidence-based practices and approaches to the work, uplift the expertise of lived experience above all, and of course, non-judgment and an open heart. This work that we do with people and families is beautiful and challenging, complex, and it never really ends. For that reason and many others, I'm so pleased to introduce our keynote speaker for this year's Rhode Island Perinatal Substance Use Task Force, Dr. Mishka Turplin. Him on the slide. I first learned of Dr. Turplin when I attended a virtual offering of his during Black Maternal Health Week in 2020 with my team of doulas. I was struck by many things, but mostly the mere fact that a white male physician was integrating the racist histories of obstetric and addiction care in this country and the lived realities of stigma, fear, and discrimination into his analysis and presentation of perinatal substance use, addiction, pregnancy, and parenting. I had never before seen a presentation from an academic researcher on this topic that was so honest and true, that centered the dignity of human beings and did not instill more fear, but actually encouraged and affirmed my team of doulas and myself to keep going and that what we were doing was needed and important. So with that, Dr. Mishka Turplin is board certified in both obstetrics and gynecology and addiction medicine. His primary clinical research, public health, and advocacy interests lie along the intersections of reproductive and behavioral health. He is medical director at Friends Research Institute, adjunct faculty at the University of California, San Francisco, where he's a substance use warm line clinician and the addiction medicine expert for the perinatal mental health lines in both Louisiana and Los Angeles County. He is co-founder and co-director of Doing Right by Birth, a nonprofit that seeks to flip the script from drug exposure to early childhood development. Dr. Turplin has spoken at local high schools and before the United States Congress and is internationally recognized as an expert in the care of pregnant and parenting people who use drugs. Please join me in welcoming Dr. Mishka Turplin.
Thank you. Uh, Thank you so much. I'm just turning on a timer. Thank you for coming here, in person and remotely, and especially now with your collective trauma, grief, rage. And I think it's really through community and connection that we help to try to imagine what really, the world we would like to inhabit looks like. I was thinking about this talk in light of the events like over the weekend, and I wasn't, completely sure. I have a clicker. Oh, I do have a clicker. How this resonated. What you asked me to talk about was sort of the intersection of gender and substance use, misuse, and addiction. And I'm going to do that, but it's really sort of in three parts. At first, I want to talk about the history of the field of addiction medicine and how it really emerges from the care of wealthy women. And was in many ways founded by the work of women physicians and researchers, and sort of how medical authority gets established around the care of women, and sort of how an uncritical take on that really perpetuates a status quo. And from that, I want to kind of use the example of pregnancy criminalization to highlight one of, sort of a harm of the current status quo and imagine, how we might sort of think of things differently. So when you look at the archaeological record, actually substance use tends to be associated with women. On the left, this is from Crete from about 5,000 years before the Christian era. It's called the poppy goddess because of the figurine, thought to be perhaps a precursor to Demeter, the goddess of harvest and the reproduction of agrarian society. You've got a Mesopotamian figure who brewing beer because beer was brewed by women. It's the first alcoholic beverage. And the goddess, there was a goddess of beer, and the earliest recipe for beer that was written was actually a poem to the goddess. You've got an Egyptian like figurine with a cannabis leaf, relates to memory and writing, which was associated with cannabinoids and was done by women. And then Sumerian sort of administration of substances like from women to women. And so, although men did use drugs, also drug use is actually part of human culture. But it's really not until the modern era, I would say, that addiction emerges as a phenomenon. And it really emerges following the distillation, manufacturing, and distribution of higher potency spirits. For example, gin. Coupled with the collapse of agrarian economies, the emergence of capitalist economies, the closure in the UK of the commons, which had been collectively farmed and herded and forced people into urban environments, and the emergence of sort of wage labor, that you first see addiction. And this is the oldest image, really, of addiction, Gin Lane from 1751. And it pictures front and center a woman who might be neglecting an infant that's falling over the railing. And that was like the first, drug crisis. And you can think of kind of addiction as being an effect or a side effect, of modernity and of capitalism. And the second drug epidemic were opioids in the latter part of, of the 1800s. And the primary person who was associated with an addiction to opioids at that point in time was a woman, a white woman, an upper class or upper middle class woman who had become addicted to opioids from her physician who had prescribed, morphine for the treatment of quote unquote female ailments. And I would say that this not only, does the sort of modern concept and practice of addiction medicine emerge in this era, in the late, 1800s, but this is also where we see the establishment of medical authority through the care of women, in particular rich women. So what happened was people were prescribed opioids for treatment of female ailments. Women developed a use disorder, and then male doctors started going into women's homes to, continue to prescribe or administer morphine to them. And you can sort of see in this, and these are some images from there, and I'll talk a little bit more some of the fiction from this period of time, but there's this negotiation of sort of an iatrogenic dependence between, the woman who's usually lying down and addicted to opioids and the male physician who enters into this private domestic space, which historically had been the realm of women. And you can see from that this slow transfer of patriarchal authority from the male head of the household, to the physician who ultimately comes, to represent the state. And initially, and this is a wonderful book that sort of describes through fiction, it's like literary criticism, looks at fiction from this period of time. And initially, addiction, among women was seen as kind of proof of their weakness, right? That they're, especially wealthy women, they're quote unquote sort of self-pleasuring through, their superficiality, their interest in shopping, in gossip, in simplistic, literary, kinds of things. And that's what kind of disqualified them from political representation. But the work of fiction actually served to change that perspective. And women went from being kind of understood as self-pleasuring and weak, hence addiction. Addiction became sort of understood as emerging from this disconnect between a society that's rapidly changing and yet gender roles remaining fixed. And it's that disconnect, that sort of like double bind in which, addiction emerges. And addiction was then sort of began to be understood as a symptom of a social disease that could be addressed, with suffrage. But it's false to say that the male doctor was the primary doctor, because this is actually also, the era of women as physicians. This is the era of midwifery, and this is the era also of Black doctors. There were more women in practice at the turn of, the 20th century, of the 19th century, as they were in the United States in like 1975. And these women did not care for the wealthy. These were women who cared, who worked predominantly with the poor, with working women with their children. And their presence, along with the presence of midwives, were actually seen as a threat to the emerging sort of medical authorities. So a couple of things happened in the early part of the 20th century that are key. The first is the passage of the Harrison Narcotics Tax Act that renders the prescribing of opioids for the treatment of opioid use disorder illegal in the United States, and basically, stops the early, addiction medicine and renders addiction, practices really outside of the healthcare system and primarily within criminal legal jurisdictions. So who a person who uses drugs, who we think a person who uses drugs is changes, from a white upper class woman to a man to a non-white person and to a poor person. The second thing that changes is who cares for people. And this follows the Flexner report, which was an attempt to kind of improve the quality of medical education. And what it did was shut all of the medical schools that were for women, and shut all but one of the Black medical schools that allowed Black, physicians to train, and really decimated any professional pathway for midwives in the United States. So I think I'll touch briefly on sort of gender, and that it's more than like, gender identity. It consists of social roles, norms, and especially reflects sort of relations of power. Simone de Beauvoir here, famous statement, one is not born but becomes a woman. Judith Butler in the middle talks about gender as performative. It's reproduced and changed in the ways that we speak and that we do. And Catherine McKinnon, sort of as from a legal perspective, discussed how, like, women can actually benefit from systems that also oppress them. And that point, that observation, was far more sort of articulated primarily through the work of Black feminists. The idea that women might partially benefit from a system that destroys them, was, articulated from the, the Combahee like River Collective, Angela Davis, who's not, pictured here, and that although women might be oppressed in the patriarchy, white women might benefit through racial hierarchies. and that creates conflict. Audre Lorde expanded that, to talk more about other oppressed identities, such as class, such as sexual orientation. All of this kind of comes together as in a really nice umbrella way with Kimberly Crenshaw's work about intersectionality. And this concept of intersectionality, I think, is a really useful way to look at history, especially sort of mid-century women and drugs. So as medical authority organizes itself in, the early and through the mid-20th century, how it reacts to women depends upon who that woman is. White women who were not in the workforce, who were economically dependent upon men, they were, came under medical authority with diagnosis and prescribing of, all sorts of different psychotherapeutics, really in a way to control their, disconnect of, no authority within, a gender normed society. But for people who self-manage their alienation, especially through the use of taking illegal substances, people who were poor, non-white, they were criminalized. And they might have been sent to what were, at the time called public health prisons, right? The hospital prisons in which, was the only place, primary place of inpatient care, really typified, through the life of Billie Holiday, a life course of gender-based violence, experiences of racism and discrimination, dismissal by health professionals, and literally hounded to her death by governmental authorities. So addiction medicine today, as we know it, the field that we know, really emerges primarily from the work of women. And this emerges during this time in which the healthcare system did not take care of people with addiction, and most use was criminalized. And everyone knows Vincent Dole, but many of us also know Ruth Fox, Mary Jean Creek, who wanted to be a surgeon, but you could not be a surgeon in the 1950s or 60s if you were a woman, so she became an internist and worked closely with Vincent Dole and then Marie Neiswander. These are considered to be, the founding figures of addiction medicine. But we always forget about Melissa Freeman. She worked very closely with all of them. She was one of 5 women to graduate from Howard in 1955. She worked in New York City, and she was actually the person who took care of the patients that were being studied by the other people on the slide. She was the first person to administer methadone to a woman, the first person to treat a pregnant person with methadone in the history of time. And she's still, I think, a couple of years ago, I know she was still practicing, and I'm not sure right now, but she is unjustly unrecognized in our history and in our field. So despite the sort of advances of addiction medicine through, like the 1990s, again, a lot of this work was, being done more by women, I would say, than by men. The focus of addiction medicine research was on the care of men, not on the care of women. And following sort of the advances of the second wave of feminism, in particular Title IX, which opened the doors of higher education to women in the United States and really led to a flood of applicants into medical school and into PhD programs, you have a whole generation of people who from across different fields, here's represented, philosophy, ethnography, and history, who examine what's happening in the care of women with substance use disorder in the United States. And they all across those disciplines come to the similar conclusions that the care of women has not changed very much over the past, 100 some years. And that women in treatment still experience, voyeurism, sexual abuse, devaluation, and there aren't really any care programs that are specifically aligned with their needs. And Elizabeth Ettori goes as far as to sort of say that the field of science around addiction and women is really a non-field. So, that's somewhere that's not a surprise. The reason, for sort of persistent gendered inequities lies in our structural relations. And Trish Homan, who's like article here on the left, has termed this structural sexism. A system, a multi-layered system, that goes from the state to the smaller units to the household and to the individual, in which in which inequities are produced and reproduced. And this concept resonates, I think, with Nancy Krieger's, eco-social hypothesis, where she talks about what she calls isms, right? Ableism, ageism, sexism, racism, and how these are structures, throughout, how we've decided to, build our universe. And to sort of borrow a phrase of hers, if sexism served no function, it would be easy to eliminate. So we're in this now, the 21st century, and there's been another shift in how we think about who a person who uses drugs is and where care should happen. In some ways, in part due to what's been called the whiteness of the opioid crisis, we've had a return to a medical and public health way of thinking about substance use. We've also had this kind of universalizing language when we talk about who is vulnerable to develop a use disorder. We say anyone can develop a use disorder. Doesn't matter who you are, where you live, or anything, we are all vulnerable. And that's definitely not untrue. But that's this kind of language of whiteness, which erases very important distinctions between, for example, the consequence of being a young Black man carrying a little bit of cannabis who's arrested versus a young white man who is. Or it erases, the difference as to what happens if you're pregnant and use drugs versus not pregnant and use drugs. And I will say that I think that language, this universal language that we use, doesn't recognize these structural inequities. And it's a language that actually accepts rather than challenges the status quo. So I want to return to that initial parable of, the origin story of medical authority and of addiction medicine, from the Victorian era. And a lot has changed in the last 100 years. The patient is actually more likely to be a man, and the provider is more likely to be a woman. And we care for people not very often in their homes, but in an entire gigantic built environment of healthcare that has emerged in this period of time. And in many ways, that environment reflects, the structure and the expanse of medical authority in that period of time. So I want to now that shift a little bit into what you'd asked me to talk about, which is a little bit about sex and gender and how I've been touching on it, but how it impacts substance use and use disorder. And how we talked about, to some extent, defined gender as being societal. And sex is biological. It's the realm of genes and hormones and things like that. And I want to say that I'm using both those terms to a certain extent as binary, and neither sex nor gender are binary. And both impact, people's health and wellness throughout the life course. And one way that they impact each other is through, like, sort of with that little arrow in the middle there is epigenetics. That's sort of like how a, biological thing can get translated into a social. It's like the mechanism of how biological things become sort of like social in presentation. And this is another way to sort of look at this. And in this is actually the only textbook that has ever been published that looks at sex and gender and health. And there's a new edition coming out. But in it, they also sort of expand that under gender, you've got some sort of environmental things, including, sort of environmental chemicals. And we think it's like in the whole drug and pregnancy space, we kind of are collapsed around psychoactive substances and don't think more broadly about chemicals and chemical exposures. But you think about how, like, endocrine disrupting chemicals that are in the environment interact with biological systems, the endocrine biological system, and how there's sex-based differences in endocrine biological systems. So you've got increased vulnerabilities due to gender, race, poverty, and things like that interact in a sex-based way that can massively influence, sort of health outcomes. And you're familiar with this slide. This is sort of NIDA's cartoon of the vulnerabilities to addiction, right? Clearly, to develop an addiction to a substance, you must be exposed to it. And they talk about two main kind of mechanisms. One is environment, one is biology and genes. So the environment in many ways is like the space of gender and society, and biology, genes, that's like sort of the sexual, the associations between sex and addiction and stuff. And really I'm going to just touch on a couple of articles that I think are key and helpful in illuminating some of this. And this is the classic study from 1989 that talked about telescoping. It was around alcohol, but this has been shown in other substance use as well. But in this, and on the right-hand side, it doesn't display super well, but it looks at that women, start using substances later, but progress more rapidly to problematic use, develop, health outcomes related to substance use more quickly, and enter drug treatment earlier than men do, and often with more severe, like, use disorder. And so their course from use to use disorder is telescoped compared to that of men. This is looking at some, I can't remember, like 15,000 people in Denmark. And here you can see that the people, like women compared to men, develop alcoholic cirrhosis and alcoholic liver disease at lower levels of drinking than men do. And we see a similar thing here, which is looking at, this was some 200,000 people who were prescribed opioids for non-cancer pain, but that women were more likely, that were actually 1.3 times more likely to have an overdose than men, and usually at doses prescribed that were far lower than that of men. But, we actually don't think of women as people who use drugs. This is a study. It was a randomized controlled trial to evaluate whether physicians or non-physicians were better at screening for alcohol use disorder and then doing a brief intervention or referring people to treatment for alcohol use disorder. The more, and non-physicians did better. To me, the more interesting thing was the gender piece. Actually, within a randomized control trial, like a highly structured context, women were less likely to be screened than men were. And women who screened, amongst people who screened positive, women were less likely to receive a brief intervention or referral to treatment. And there have been several like really nice studies that have looked at the the impact on mortality, in particular midlife mortality, of the opioid crisis. And this is, I think, one that took the longest view. And in this, they said that there was what they called a pronounced female disadvantage for, in particular, midlife aged individuals between 1999 and 2007, that compared to men, women had 1.4 times higher a relative increase in overdose events, 3.4 times higher relative increase in alcohol-related liver disease, and 1.5 times higher increase than men of suicide. And probably, arguably, one of the most important studies from the 21st century is the Kaiser ACEs study. And you all know this, but ACEs, adverse childhood experience, are experienced more by girls than by boys, primarily because of gender-based violence and abuse, both emotional, physical, and sexual abuse. And there is literally a dose-dependent relationship between the number of adverse childhood experiences and starting to use a drug, injecting a drug, or developing a drug use disorder. But despite all of this, I think our science is still imbued with like a male bias, I'll say, both in terms of how we ask questions, like the so-called objective gaze that's supposed to be of science, as well as who we think the subject of research is. And I think if we don't critically examine gender and also those other isms, we'll continue to reproduce this sort of male bias, both of what questions we ask and who we are asking them of. We're going to continue to kind of individualize what are actually social phenomena at the bedside, and really neglect attentions in particular to relations of power and oppression that express themselves as illness and disease and other things. And so finally, I want to turn to the example of pregnancy criminalization as a way to illustrate how, if we don't interrogate the status quo, we perpetuate harms and actually reproduce, and they start to increase. And the term pregnancy criminalization was relatively recently coined, and it's going to mean something slightly different across some of these studies I cite. But generally speaking, it means one of two things. Somebody is criminalized for something that is uniquely pregnant, i.e., miscarriage, stillbirth, or somebody is like their course through the criminal legal system differs because of their pregnancy. So for example, like it might be a misdemeanor to use a drug, but it's a felony, to administer a drug to a minor or to a fetus. So pregnancy criminalization consists of both of those things. And ProPublica did a study about this about 10 years ago, and they said that the first known indictment of an American woman for drug use in pregnancy was in California in 1977. And in 2005, they'd found cases everywhere but those states, including Rhode Island, in which somebody had been criminalized or prosecuted for substance use. I will say since then, Rhode Island has prosecuted people for substance use. Lynn Paltrow, who was the founder of something called National Advocates for Pregnant Women, now it's called Pregnancy Justice, did this had a slightly different definition than ProPublica did, which is why she found cases before ProPublica found cases. She looked at arrests and forced interventions in pregnancy. And this is starting post Roe, is why she picked that date. And overall, there were about, like 400 some cases over this period of time, 84% of which involved allegations of illegal drug use. Now, Pregnancy Justice redid that analysis, looking at from 2006 to 2022. And this is sort of the map of the cases, and you can see a concentration of cases, especially in the South, in Alabama, South Carolina, Tennessee, Oklahoma, and Mississippi. And all of those states but Mississippi had, at some point in time here, either through like a judicial decision or state statute, redefined child to be inclusive of a fetus. And most recently, a couple of months ago, Pregnancy Justice updated, this pregnancy criminalization surveillance to look at what's happened in the couple of years since Dobbs. And they found 400 some cases in that period of time. So putting these three studies together, and the definitions differ a little bit, you can see a couple of things. One, it appears that the number of cases is increasing. Two, whereas earlier, like, in the 70s, 80s, and 90s, the majority of people who are criminalized were Black. Now the majority of people who are criminalized are white. There's no change in poverty. Overwhelmingly, these people who are criminalized are poor. Sometimes that's measured whether or not they have, public defender versus a private lawyer. The proportion of pregnancy criminalization cases that involve illegal drugs has increased. It's almost all of them now. And the substances have changed, where it was primarily earlier driven by, the crack baby panic, that racist, false narrative. Now it's overwhelmed. It's primarily, amphetamines, followed by cannabis, followed by opioids. And you'll note that 5 or 8% of these cases actually involve people receiving medications for opioid use disorder. And perhaps most importantly, and what I want to dwell on for the end of this talk, is the role of the health professional, like in these reports. That now 2/3 of these cases either originate from a notification from health professional, or the health professional is closely involved in the criminalization of the person. Interestingly, we had anticipated that post-Dobbs, many of these cases would actually be about abortion, but they're not. 2/3 of the cases actually are from a live birth. And the next, largest group are from sort of miscarriages or stillbirths at, close to term. And the types of charges, the most common type of charge is actually child abuse, neglect, or endangerment, not, some of the other ones. So this really points to, I think, the relationship between the practice of healthcare and sort of the criminalization of the people that we serve. And one of the ways that this happens is through sort of over-testing and over-reporting to child welfare. There has been a marked increase in the number of separations, especially for young children in the United States. And whereas the leading reason for foster placement for children is neglect, for infants, it's parental substance use. And there has been no change in the last 2 decades in the number of reports to child welfare that come from the police, come from the family, come from child care, come from anonymous sources. The only category of reporter that has increased has been health professionals. And there's been at least a 400% increase in reports that originate from health professionals over the past, 1 to 2 decades. And this is sort of augmented existing racial inequities within the child welfare system, as illustrated by these data here. This is looking at cases that originated from a health professional that were screened in by child welfare and stratified by the race of the infant. And you can see overall an increase, but a much more rapid increase. The second to highest green line are Indigenous children, and the top line are Black children. So a widening, increasing inequity in who gets screened, who is reported, and who is screened in by the system. And I would say that this is evidence that health professionals are complicit, in the state violence of pregnancy criminalization and family separations. And nowhere closer is policing and clinical care than during the birthing hospitalization. And when we provide care that is carceral, it's not really care. And it also, I think, causes us, it's a form of moral injury, right? When we're working within systems that don't align with our values, that disconnect, creates a dis-ease. So I would say that pregnancy criminalization emerges and is reproduced, it's from the state, there's mandated reporting, fetal personhood certainly figures strongly into it, how this sort of intersects with the prohibitionist drug regime, the quote unquote crack baby was described as where the war on abortion collided with the war on drugs. And all of this is like, it is an example of like an iatrogenic injustice. That means an injustice that comes from the house of medicine. But it's an injustice that I think often arises not from intentional or overt malice on the part of a provider, but really sort of the unexamined and normative ways that clinicians sort of enact authority and provide care. So the question to me, and this is not just a question for pregnancy criminalization, you can ask this question of any system. Is the system broken, or is it functioning as it's intended? Is child welfare broken, or is it functioning as it's intended? If you think the system's broken, you're a reformist. You're going to fix the system. If you think the system is functioning as intended and you don't like how it's functioning, you're an abolitionist. And you need to imagine what an alternative system might look like. And this is this idea of a horizon, right? What is the world we would like to inhabit? And then after you articulate that, how do we get to there? So I encourage you to sort of think about what's the world we would like to inhabit. And then we can think about sort of how we get to there. And in closing, I want to kind of walk through that in sort of 3 different domains of questions. And the first is really sort of to widen the lens of what we ask, right? As a medical student, we're, like the question, what is wrong with the patient? That's an important question to ask. If you add like a layer of ethics, the question is, am I doing right by this patient right now? Also important. But when we think about justice, the question becomes, are the rules, money, power arranged so that all patients can reliably get care without harm? A second thing is to really ask and answer ourselves, like, what are women? And this sounds superficial, but I think the question is important. If we think gender's just about identity, or if it's about sameness or difference, if we think of women as like little men or men who menstruate or things like that, we can actually, we neglect, I'll say, recognition of how power and oppression and structure and sort of the exercise of an uncritical medical authority perpetuates a status quo of discrimination. And finally, like, there's been a huge advance in addiction science over the past, couple of decades. And it's important to look at the brain. It's important to understand, transmitters. It's important to, drug development is important, and research on interventions to improve care. All of that is really important. But it doesn't really answer, I think, what's, to me, the more important question. It's not what is addiction, but why does addiction become us? What is it about the way that we live that creates and sustains so much, chaos, self-medication, trauma, and the, continuation of that, throughout families, societies, and communities? What is it about us as a culture that makes addiction become us? And I have answers to that, but more, I think it's about the process, sort of thinking about how we, get to there, and to think about the work that we do, as sort of more, not reproducing social norms, but sort of resisting and transforming them towards where we want to be. To rethink equity, not as a project, or equality, not as a project of sameness or difference, and really to imagine what life might look like. Really, it would be more a gender abolitionist perspective to imagine what life looks like sort of after the patriarchy. And to do this, we have to do this in partnership, right? To listen and learn from women who use drugs, from their embodied knowledge, from their experiences, to listen to women who are providers, which is the exact opposite of what all you are doing here right at this moment. And for us to kind of purposely put ourselves in uncomfortable positions, be it in sitting in, trying to sit in community with people who are different. If it means sitting down and reading stuff that we're not used to reading, feminist philosophy, anti-racism, queer theory, so that we can better ask, or we can ask better questions so that we can ultimately, sort of provide better care. And with that, I want to stop. This is some contact information. That's Doing Right by Birth is the org that Kima and I set up, that Arlo mentioned. And on the top left, this was something that I had AI put together for me, a decriminalized healthcare image, which anyway, so that's like another way to talk about this, is just to really note one way that we resist, the increasing carcerality of care, is to think about how we decriminalize the healthcare that we provide. And with that, thank you, and I'm happy to answer any questions.
Hi, my name is Jesse Andrews, and I represent Weber Renew. My question for you, by the way, you did an excellent, excellent presentation, because I'm transgender, and the way on how you broke it down from the images, it took me back to the era that I'm in now. And I got to see how the woman's shapes are now looking. Now it's coming back to that. My question to you would be, how long have you been in this field, and what knowledge do you really have on transgendered health, besides working with women and transgendered individuals? Because I think from your presentation that I have taken from it is that we are born unique, and it comes from this side to this side. And as me being a transgendered male to female, I'm now understanding my gender because I'm a woman. So my question to you would be that.
Yeah, thank you.
You're welcome.
how long have I been in the field? Depends how you count. But since sometime in the 90s, um, uh, this is not answering your question, but as I collect my thoughts in the back of my head, I'll share it. Like I really, when I um before I used to work in syringe services in San Francisco before and then during when I was in medical school, and when I was in training in Los Angeles, uh, I was the only provider who would prescribe hormones to patients. It was I was trained as an OBGYN, but transgender people seeking like hormones, especially estrogen and stuff, I would, and then over time other people would provide it. I apologize in that you're absolutely right in that in like how I put this together, I did not, I definitely did not center this um, uh, on the both the sort of reality um, and care of transgendered peoples. Um, but I do, and some of it is because I think, as you recognize, that uh, uh, like I haven't totally come up with a good way of speaking some of it, and it's not, and I need to. Um, like that's what I when I talk about making yourself uncomfortable by putting yourself into like unfamiliar community and putting yourself into like conversation through reading through different sorts of things. It's a I am on that process. But I would say, and I'm also aware that there has been uh some real like kind of like backlash, not just recently without a doubt, but also, amongst kind of like the second wave of feminism over like who is a woman, what is a woman, and whether or not like transgendered people should be included or not included in particular sort of like feminist structures. And and that and today where we're seeing like this is like how power operates, right? People who are the most vulnerable are the most impacted. And you see that like just within my research world, with the restriction in NIH funding, the people who are most impacted are actually the people at the beginning of their career who are more likely to be women and people of color. People like me who are like established aren't as impacted. People who work with more like communities that have been rendered more vulnerable, like in particular like sexual minorities, trans folks, people who use drugs, they're more vulnerable, like just from who they who their where their research monies go. But that's also true more broadly, right? People who are here with, like, people who are immigrants are more vulnerable than people who aren't. People who, like trans folks, are more vulnerable than, non-trans folks. And that's kind of, that's always somewhere that's always the case. Those who are rendered more marginal or more vulnerable to power. And that I think the inverse of that means that we have to pay attention to, and we actually have to, fight for, the rights, dignity, and humanity of those who are most vulnerable. It might not be affecting me directly, but that's an injustice that ultimately, comes like to us. So I don't know if that answers your question, but I really, I'm gladly challenged by it.
Hi. Um, I just would like to know when you are talking about discriminating healthcare, You are talking about when baby are taken away from mother just because they test positive to drugs at the hospital.
In part, yes, that would be an example of it. So decriminalization of healthcare would be to first sort of recognize our like complicity with policing and criminalization, like within the practice of healthcare. And further, if you back it up further, like what is medical authority? Like, is it transformative? Is it person-centered? Is it moving towards justice? Or is it actually reproducing social norms, which are reproducing structural inequities and injustices? And so to try to think about the work we do as being justice oriented, not, status quo. And one example of that would be how policing enters into birth, through unindicated drug tests and reflex reports to child welfare and their consequence. But there's lots of other ways that we exert, a normative authority through the practice of medicine. And nowhere, I think, is it more clear than at birth, but it's not only at birth.
Thank you.
Hi, my name is Tosin. I'm a pediatrician and I also work at the health department. My question, thank you so much for this amazing talk. I have, I think, two parts to my question. So one, thinking about Rhode Island, and the services that we have here and the services that we don't have. You talked a lot about autonomy. How important is it, for the population that we serve to have options for pregnant people, whether that's inpatient, outpatient, for them to choose the type of care that they want? And then the second part, what does this look like every day in terms of decriminalizing healthcare? You talked about some of us, reading things that make us uncomfortable. Is the change through reading and education and osmosis, or is it policy change? What does it really require?
Let me start with the last one. All of the above, but and more. So examples of here's an example of decriminalization in the healthcare setting. This would be it's a couple of places done this. UCSF has done this, and imperfect, but the idea is they call it a child welfare timeout. So an infant is identified as perhaps going to be reported to child welfare. Now, we have within mandated reporting has this artificial sense of urgency, right? Like this policy-wise, it comes from CAPTA, Child Abuse Prevention Treatment Act, designed to respond to child abuse. It makes sense if you think a kid might be being abused at home, that you make a quick decision about placement because there's a true urgency to that. When you're responding to a positive drug test, there's that same administrative urgency, but that urgency is false, right? It's not the same as responding to child abuse. So you want to kind of like hit the pause button. And so what they've set up is something called a child welfare timeout. Before the report is made, there's a meeting with the patient, whoever they designate, that they want to be there, the care team that knows the patient and the person who might be making the report. And they try to come up with an alternative to a report that centers on the person. What are the services that this person actually needs? Like, can we provide them in lieu of making a report? And actually, the so-called plans of safe care, I think that's what you call them in this state. They're called family care plans in other places, which is kind of a nicer term because it takes out the word safety and centers it on the family. But that can be a really good mechanism to kind of try to do that. And because another thing I'll just say about the mandated report for substance exposure, what it does to health professionals is it sort of offsets the responsibility of care from the health system that's actually resourced to provide care to a surveillance authority that actually in and of itself doesn't provide care. It can mandate services, but child welfare is not a service provider the same way the health care system is. So that would be another example, is like, hitting the pause button, or thinking about your hospital policies, like your drug testing policies. What do those look like? Are you testing, for medical indications only, or is this kind of like a quasi, parenting test? What are you doing, with autonomy? Like, what if somebody refuses a drug test, which is completely legitimate? What is the, institutional response to that? Are you just testing the baby as a way to get around, as a way to kind of violate, that person's autonomy? In terms of sort of autonomy and choice, yes, is a short answer to that part of that question. But it's also not that simple, because I would just urge a little bit of critical caution that when we are from a public health agency perspective, right, all of the solutions might be structural, but and that doesn't categorically center on the person. And I think that there's what I mean by that is that, and I see this in the court where we, remand people into treatment, right? With no real recognition that, one, the treatment might not be truly available. The treatment that exists might not be person-centered, might not be welcoming, might not be safe, might not be evidence-based. And then when people don't engage in our systems and our prescriptions, that is licensed to punish them. And I think that that's unfair and not like sort of person-centered. So thinking about how can we support people, and, in their, on their, recovery journeys and their, regardless of what their individual decision-making is at that point in time. And I think from a public health agency perspective, you can't do all of that. And that's where, like, it's critical to partner with community and with community-based organizations. And I think there's a really strong role in, harm reduction, reproductive justice, like all the different groups and people that exist within a community to help, serve as the glue, maybe sometimes the navigator, certainly the support, and that support should be recognized as legitimate, by the state, be it either the public health authority of the state or like the state, i.e. in family or criminal court.
So I have to cut off questions so we can sort of protect the flow of the conference, but Dr. Turplin is here and I'm sure he'd be happy to talk to you. And just so you know, we just renamed Plan of Safe Care to Circle of Care Plan for that very reason.
Yeah, perfect.
Because it's implied that your baby's not safe if you don't have the plan, right?
Exactly.
So thank you very much.
Yeah, thank you.
So I have the distinct pleasure of introducing Doctors Jean Toomey and Lynn Andriozzi, both from the Brown Center for the Study of Children at Risk at Brown Alpert Medical School, Women and Infants Hospital, and Community College of Rhode Island. Maybe we can close that back door. So Dr. Jean Toomey is a clinical social worker who is an assistant professor of psychiatry and pediatrics at Brown Alpert Medical School. She is a child and family therapist with extensive clinical experience in infancy and early childhood. She is the co-director of the Family Care Follow-Up Clinic, also known as FCFC, that provides services to infants and their families when there has been opiate exposure during pregnancy. Her clinical work at Women and Infant Center for Children and Families includes treating parental stress and depression, including postpartum mood disorders, helping families whose infants experience cry and sleep problems, and outpatient therapy with young children. Her research interests include parenting abilities of women with substance use disorders, developmental outcomes of substance-exposed infants with child welfare involvement, and the impact of infant regulatory difficulties on parental mental health. In 2010, she was named Social Worker of the Year in Children and Families by the Rhode Island chapter of the National Association of Social Workers. She served as Vice President of the Rhode Island Association for Infant Mental Health for over 10 years and has earned endorsement as an infant mental health clinical mentor. As a consultant to the Rhode Island Association for Infant Mental Health, she provides individual and group reflective supervision consultation. Dr. Lynn Andriozzi Fontaine is a professor in the psychology department at the Community College of Rhode Island and an adjunct associate professor of pediatrics at the Brown Center for Children at Brown University Medical School. Her research and clinical interests include the neurobehavioral development of infants and the developmental outcomes of preterm and substance-exposed infants. Lynn is also the co-director of CCRI's honors program and has been involved in various educational initiatives and conferences, including presenting at the National Collegiate Honors Council Conference. Please join me in giving them both a very warm welcome to the stage.
Thank you, Arlo, Margot, and team for providing this wonderful day for us today. This morning, Jean and I want to share the importance of early healthy relationships. Sorry. We see the infant as the cornerstone of the work, and we want to underscore how we bring the baby into focus. Infant mental health is everyone's business. Most of us are doing infant mental health work, even if we don't define it that way. Everyone who touches the life of a child in some way can promote early healthy relationships in social, emotional well-being. So the definition of infant mental health, it refers to the capacity of children to form close and secure interpersonal relationships, to experience, regulate, and express emotions, and to explore the environment and learn. All of this is in the context of the family, community, and cultural expectations. The development of these competencies is synonymous with healthy social and emotional development. And the infant mental health perspective helps us to be non-judgmental. Again, infant mental health is everyone's business. When we take an infant mental health perspective, we have some guiding principles. We take a relational framework. Relationships are at the center of all development, and our work is multi-generational. We see the need for positive, nurturing relationships. We support parents to develop more gratifying relationships with their children. And we try to better appreciate the infant's experience. We take a strength-based approach, and we focus on hope and resilience. Sometimes those strengths are obscured by needs, but we try to identify strengths to build confidence and address problems. We try to recognize what parents are doing well and what the infant is doing well. We take a prevention orientation, and we try to address parental mental health needs to promote positive infant relationships. And we often hold that there is no one right way to parent. Good enough is good enough. And we also see ourselves as a multidisciplinary team. Infant mental health specialists take a non-expert stance with families, and we recognize that parents are an important component of the team alongside all of you from fields like pediatrics, social work, mental health, early intervention, home visiting programs, court, child welfare, etc. We'd like to stress the cultural context again. We are impacting at least 2 generations, if not more. Culture is the lens through which children and adults understand the rules of relationships. We recognize that infant mental health can be interpreted differently in various cultures. Families express themselves and their beliefs in different ways. And families engage in child-rearing practices consistent with their culture and beliefs. They learn what they can expect from other people. We recognize that the tasks of childhood are enormous and profound, and the completion of those are equally so. The child needs, within the framework of their culture, to feel safe, heard, known, and important to somebody, and optimally multiple somebodies. What this underscores is that there is always another person. There is no such thing as a baby, meaning that if you set out to describe a baby, you will find you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship. We thrive within relationships. Having that person is a core need. Sometimes we might ask ourselves, why is the work so hard? Because we recognize that working with children and families is unique because there are multiple relationships to consider and support. We recognize that infants' emotional, social, and cognitive development evolves in the context of their caregiving relationships. To optimize a child's functioning, we need to support the infant and caregiver. And young children are also highly sensitive to the emotional well-being and life circumstances of their caregivers. So we often think and recognize that there are layers of experiences that impact the parental mental health, impact the dyad, et cetera. So some of these layers could be parents' own attachment in their own early relationships. Was this a planned or an unplanned pregnancy? Parent age, any trauma or loss history, a history of interpartner violence, child welfare involvement. Has there been any perinatal or prenatal loss? Any disruptions? Any parent hospitalizations, infant hospitalizations, a preterm birth, perhaps? We recognize that the caretaker may have some mental health challenges, some concerns with mood or anxiety concerns, some concerns with substance use. And we recognize that children, particularly those infants born prenatally exposed to opioids, might present some caregiving challenges. And so therefore they might present with things like excessive crying, disrupted sleep, some feeding difficulties, or temperamental or a difficult temperament. There can be both ghosts and angels in the nursery that will impact the emerging attachment relationship. We are taking a multi-generational focus in how the past influences our current are present. Selma Freiberg says, in every nursery, there are ghosts. They are uninvited visitors from the unremembered past of the parents. The baby makes her or his own imperative claim upon parental love, and in strict analogy with the fairy tales, the bonds of love protect the child and her or his parents against the intruders. A child needs a secure partner to rely on to meet their needs. So that brings us to the concept of attachment. We acknowledge that relationships matter. So think about your own relationships. Think about the people in your life that you have an emotional connection to. We know we have that connection because of the fact that we like to be with them. We enjoy their company and experiences with them. Attachment theory's implications are central to our work with infants and their primary caregivers. And attachment theory is attributed to John Bowlby, who defines attachment as an enduring emotional connection between the child and a specific individual, the attachment figure. That's characterized by a tendency to seek and maintain closeness to that figure, especially under conditions of stress. It can be fear, fatigue, illness, etc. And the attachment relationships are central. They can be either protective or a risk factor, depending upon the relationship. Bowlby believes that there's a biological basis or an evolutionary basis to this. He believes that infants are hardwired to signal, and the caregiver is primed to respond to those signals. So I want you all to imagine that you hear a baby crying on an airplane. After the initial eye roll, think about what you feel. You physiologically feel it, right? You feel it. And what do you want to do? You want to respond. We want to help the baby stop crying or comfort the caregiver in that very uncomfortable situation. And so I like to think of this as a dance, that the infant who's hardwired to signal and the caregiver responds. And forgive me for having a rhythm, but the infant signals and the caregiver responds, and the infant signals and the caregiver responds. And back and forth it goes like a dance that unfolds over the first few years of life. And so what we're really talking about is a pattern of care. This is a process that occurs over time. And we see the attachment, how it gets revealed to us, is in the baby's organization of behavior. So it is essential for mental health is that an infant and young child should experience a warm, intimate, and continuous relationship with his mother or mother substitute in which both find satisfaction and enjoyment. Again, this occurs over time. For a baby to learn who the caregiver is, they need continuous and responsive care. And again, this takes time. Remember the notion of good enough. We cannot be 100% all of the time. We can't. There is a notion that if you meet your child's needs 30% of the time, they will grow to be emotional, secure adults. The percentage really doesn't matter. That percentage doesn't matter. What really matters is in the times, the 70%, when you miss, that you go back, that you strive to address what was missed. And the repair is the key. Attachment theory has generated a number of evidence-based interventions. And attachment theory is influential in many applied settings, many of the settings in which we work every day. So here's how it works. We need to highlight the foundational nature of the first few years of life, establishing those patterns of connection. And the quality of that matters. So after those patterns are established, what the infant does is form a mental model of the quality of that relationship. This is what Bowlby calls the internal working model. It's like an idea. It's an idea that the infant has in their head of their primary caregiver. The infant learns what to expect, and their behavior reflects that. So if the infant expects the caregiver to be responsive, they will signal their needs intentionally They're going to expect that those interventions and responses are going to be effective. And what that does is, leads them to have the confidence to go and explore the environment. And that's what we as professionals are looking at. We're looking at that behavior. We're paying attention to, and why we're recognizing that making sure infants have those people, like why that's so critical. Bowlby defined this internal working model as being fluid. It's a fluid blend of real and perceived events. And it allows for the concept of change as new interpersonal experiences are processed. So we're not going to get into the specific types of attachment, but here's how it would look, or here's how that dance might look in a secure attachment. The child has a need, and then they signal. They signal through the expression of their emotions, of their behavior. And that might specifically look like crying, smiling, pointing, eye contact, reaching. And then the caregiver perceives that signal and then responds to that signal. And that helps the infant anticipate future responsiveness through that dance unfolding, through that pattern that unfolds over the first few years. That's what happens. So we'd like to shift a little bit and show you what that looks like. So we're going to focus on face-to-face interactions. And we'll focus specifically on the still face experiment developed by Ed Tronick in the mid-70s. It is a procedure in which involves several episodes. The first episode is which the caregiver interacts with their infant. And then in the next episode, they stop responding and they maintain a still face. It is a face that is without emotion, a blank look, no smiling, no laughing, no talking. And then in the next episode, they resume interaction later. What we know from the still face experiment is that infants typically show signs of distress and try to re-engage the caregiver during that still face episode. And what it shows us is it demonstrates a baby's need for responsive social interaction. And it highlights the importance of reciprocal interactions, or how critical those reciprocal interactions are for the infant's development and their ability to regulate their emotions. So we'd like to show you a mom and baby dyad that do it really well. So, let me see. So in this first episode, what you're going to see, I've cut down the clip so it doesn't take up too much space or time, but what you're going to see is you're going to see synchrony. There's a lot of give and take exchange, a back and forth between this mom and baby. There's enjoyment. She's playing with him. She's playing games. She's playing pat a cake, and he's going to smile. He's going to vocalize. And when he looks away, she waits just a few seconds to resume the game. They have mutual gaze and eye contact. So here you go.
Here we go. So straightforward. Just say, repeat it. Look at mama. Don't get the bed for rub it mama. Rub it mama. Rub it mama. Don't get the bed for rub it mama. Rub it mama. Take it me. Baby skin.
So clearly there's some mutual enjoyment there, right? On both of their parts. So in the next episode, we'll go to the still face episode. He initially is going to vocalize. And then he's going to show some signs of stress. He will yawn. He'll do some back arching, like he wants to get out of the chair, kind of like what this still is showing. He starts to get upset by the end of the clip. But I want you to remember that behavior is communication. He can't say to us, hey, or to his mom, hey, where'd you go? Mom, this isn't what we do. This isn't who we are. I don't like this. He can't say that. Okay. So clearly, by the end of this, he's not liking it. Does get, I will share, he does get a little bit more upset. And then we come to, after this rupture, we now come to the repair. And so what you're going to see here is the mom is going to name it for him. She's going to ask him, are you upset? She's going to wait for him to make eye contact. She kind of paces her re-engagement with her pat a cake game. And she even might say, talk to mama.
Mama, baby. Oh, you upset now? You upset? Are you upset? Are you upset? Are you upset? Are you upset? Oh, you upset? Are you upset? Don't you try it. Don't you even try it. Don't you? You talking to mama?
So then there's a nice repair after that initial rupture. And then they continue on and go back to interacting as they normally did, or as they did at the beginning. So sometimes what happens is that there is a negative attachment cycle and it doesn't look as nice as what we just showed. Again, to talk about the dance that happens, the child has a need. They signal that they have a need through the expression of their emotions and their behavior. Again, that might look like crying, like the infant in the picture. But now the caregiver misses or inaccurately perceives or is overwhelmed by or is unable to meet the need. And that cycle leads the child to anticipate future unresponsive relationships. Remember, it's the pattern of care that's important. And we do have to keep, remembering that good enough parent that we can't hit 100%. So now I'm going to turn it over to Jean and let her talk about some things that are strongly correlated with secure attachment.
So what we're going to do now is discuss how infant mental health principles can be applied to work with families to promote secure attachment and healthy parent-infant relationships. And we'll be focusing on reflective parenting and attachment-based interventions. So when we think of what we're doing when we speak of reflective parenting, we're trying to understand what the child is trying to convey. We want to help parents imagine what their child might be feeling to figure out how best to help, and to help parents be curious about the child's experience. In doing this, it also is likely to help parents reflect about their own internal experiences. And optimally, what we want to see out of this is that parents can respond with warmth, comfort, and support because they understand what the child is feeling and what the child needs. And I think you saw that very nicely demonstrated in that clip that Lynn just showed in terms of the mother coming back. I really like how she allowed the baby some time to express his upset because he had a reason to be upset. There are other still face films that we have where the mother is just in there very, very intensely, as if the baby has no right to be upset and wanting to fix it, but in a way that doesn't allow the infant to communicate what the experience might have been like. As Sally Provence said, don't just do something. Stand there and pay attention. Your child is trying to tell you something. And what she means by that is that it's important to be present and attentive rather than immediately trying to fix something. Oops. In promoting reflective parenting, we want parents to feel nurtured in order to help them nurture their babies. When a mother feels she's attended to, she's more apt to form a relationship with her infant mental health clinician or whoever the provider might be who's working with her, and in turn form that better bond with her baby. So it's important for all of us to be sensitive listeners to a mother to help her be more responsive to her infant so that as she feels understood, she can help understand her baby. This also affords mothers an opportunity to reparent themselves in ways that may have differed from their own experiences as a childhood. So the mother can become the mother maybe that she wished she had, as well as becoming the wish for mother for her child. We know that there are difficulties in terms of becoming reflective. Selma Freiberg recognized that early relational trauma profoundly impacts parenting, and this became a founding premise in the field of infant mental health. Parents who have their own childhood traumas are likely to repeat the past when confronted with their own child's helplessness and distress. And parental relational trauma can make it difficult to recognize and respond to the child's distress. So often the parents with whom we're working are under a high degree of stress, and that leads to an ability to nurture and experience pleasure being compromised. And I think it's important to think about the notion of pleasure. As Bowlby was saying in that quote about fostering mental health, it's important to get satisfaction and joy. And a lot of the parents with whom we're working have a hard time experiencing that sense of playfulness, of joy, of satisfaction. But we have to realize that it's very difficult to keep the child in mind when a person is fighting for their own survival. So in the clinical work that we do, we want to try to foster a corrective experience. So the first thing that needs to happen is provide a sense of safety and teaching a reflective stance through how we reflect and how we want the parent to be able to reflect and make connections. So simply put, what this means is providing a sense of, I've got you. When you're here, you're safe. This is a safe environment for you, which you need to be able to experience that vulnerability that goes along with looking more closely at internal states. The other piece of that equation is I get you. that I'm trying to work with you so that we both can understand you better. This is very similar to what we talk about when we meet, when we talk about the parallel process. I think Selma Freiberg sums it up very succinctly when she says, when the mother's cries are heard, she will hear her infant's cries. And that's why it's important to be listening to the parents with whom we're working so that they can feel listened to and they can listen to their children. Infants who have prenatal opiate exposure often may have impaired ability to regulate states of wakefulness, sleep, and may experience greater distress, which in turn requires more parental help. They may be paired with a caregiver who has some difficulty reading their child's communications. And as our colleagues from Yale have noted, from all of the existing risk factors found in situations of substance abusing mother-baby pairs, the most important one from the point of view of the baby is that the mother is not able to pay enough attention and keep the baby's experiences and needs in her mind. So we really want to bring the baby to the fore and think about, how do we become the voice of the baby? How do we bring the baby into the conversation? As a start, we want to encourage parents to ask questions about their baby's actions. Through observations with parents, we want to think about different ways to interpret the baby's behavior. We want to find that voice for the baby. We want to try to consider the infant's communications from the infant's perspective. And always in our observations, we're in a developmental context, thinking what infants are needing at the particular developmental stage that they're in. We're also providing developmental guidance for thinking about what's going to be coming next. And really at the center of this is helping parents think about their infants' emotional and developmental needs, really recognizing that the infant has an internal world just as the parents do. So this is a picture from a book of baby animals that I have. And I don't know if you can see clearly, but there's a baby in that formidable jaw. And I don't know if you have any reactions to that, but you could maybe imagine that you think, gee, I got to get that baby out of there. But in fact, what the book tells us is, in fact, this is how a baby crocodile stays safe. It takes a ride in its mother's mouth. And so what maybe at first looked like a very dangerous situation, in fact, is the opposite. You look and then you think, well, gee, actually no one is going to try to hurt that baby, not with those jaws around it. And this brings us to the importance of keeping mothers and babies together. We have had, as our speaker this morning was saying, we have had a very long history of having a knee-jerk reaction to removing infants from their mothers. We have a long history of criminalizing women who use drugs during pregnancy. As our other speaker this morning was saying, even women in recovery are treated with stigma and disrespect. But we have many people, and certainly in this area, we have our own Barry Lester, who's our director over at the Brown Center for Children. Up in Cambridge, we have Norma Finkelstein, who for years, they both have been advocating the importance of keeping mothers and babies together. Norma Finkelstein early on was talking about the importance of relationships in women's lives at a time when the substance abuse field was saying, first you have to work on your recovery, and then and only then can you parent. And we know how detrimental that was. So whenever possible, women using illegal substances during pregnancy should not be separated from their infants. What we need to do is provide them with the support and services that they need to successfully parent those children. What we found is that when treatment programs include a parenting component and services for children and families, there is a higher rate of treatment success. What people have found is that rather than waiting and working on the substance abuse treatment, that in fact, bringing in those children, helping women to become good parents impacts their positive recovery experience. Also, it's a better developmental outcome for the children, and it establishes family stability. So really, very, very positive outcomes when we keep babies and mothers together. I think all too often in our discussions, we forget about the baby. And the loss of a primary caregiver in an infant's life is huge, and it is life changing. And this is another reason why it is so important to think and think again about removing a baby from a parent. Because as we see, as Lynn and I see in our work, even when babies are reunified, if it's been, and often it would be 12 months. Now it's changed. I think things are changing. We were talking about this on our last call. We are seeing, I think that, I'm looking for Joe Carr, there you we are seeing that DCYF, I think, is really making an effort to keep babies and their mothers together, and that they are not waiting as long. But historically, what would often happen, at least in my work with children where there is child welfare involvement, around 12 months the child would be reunited. Well, in that time, the child's primary attachment figure has become the family with whom they've been living, and it's a loss. So, I mean, we know from the start that there is going to be a price to be paid for the baby. Very, very, very easy to forget about the baby. Why? First of all, they don't talk. So they're not telling you. They're not looking at you and saying, hey, if I have a vote in this, this is what I would say. The other thing I think that we all too often do is say, what? It's just a baby, right? It's just a baby. They're not going to remember this. Well, they're not going to remember this in the way that we, as further along in our development, remember things so that we can sit and talk about them, but they will remember it. They're pre-verbal memories, and those are very, very significant. So we know it's been well established. Winnicott told us many years ago wisely that there is no such thing as a baby. There is always that baby and a primary caregiver. When that person is absent, the child's world no longer makes sense to them. And they have a very hard time making sense of it because so often we as adults avoid ways of talking to them about it. So make no mistake, infants mourn. And if you have ever seen a depressed baby, it's quite remarkable because it's so antithetical because of what you think of as a baby. We see depressive states in terms of changes in their eating, their elimination, and their sleep. With older children, we might see some naughtiness, however that might be manifested. Worst of all is when infants or children kind of lose the desire to relate to others because it becomes too much of an effort, too much of a heartache. You know, how many songs have been written about, I'll never love again because of how heartbroken you are. Well, in a much deeper way, that can happen in infancy and early childhood, which we absolutely do not want to have happen. Whoops. So let's think about attachment-based interventions. We, of course, need to recognize that families in which there's substance abuse face multiple crises and often chaos in their lives. So they, of course, first of all, need help establishing stability. That's part of creating safety. And that's also part of understanding a person. You can't have someone sitting in your office saying to you, we cannot afford toilet paper, and then be, well, yeah, right. So you can't just ignore that. So often we need to provide for behavioral strategies for regulating emotion and concrete problem solving, but we don't want to lose sight of these mentalization skills that we've been talking about. Because again, we don't want to sell people short, that this doesn't just become about very superficial interventions, but to say you deserve to have a deeper understanding of how events have impacted your life and how they're impacting you as a parent now. And so we're going to work on this together so that maybe ultimately we can create more coherent representations of a caregiving narrative, create a more coherent narrative of your life experiences. So you, with this new baby, can help that child create a coherent world in which to grow up. We have found that when there's more improvement at this representational level, not only is there improvement in the behavioral level, but the improvement in the mother's interactions with her child. And so that's why we think maternal representations are an appropriate target for clinical interventions to improve parenting of young children. Caregiving is based on these underlying representation and mental states. So we want to work at that level, and previous interventions targeting only behavioral change we see do not actually do much to improve caregiving behavior, because it's not about the relationship. And this, I think, the most important thing that we're not maybe saying clearly, we think it's obvious, but at the heart of infant mental health is the relationship. It's all about relationship. And how do you develop relationships? It's by being understood. It's by being understood. And feeling that that you're important enough that I want to understand you. Many of the mothers who we see are coming to us who have not had someone in their lives who is saying to them, you know what, you are the apple of my eye. You know what, I really, really love you. You're cute. I love you. Right? Uh, and to say, so even when a child is coming to a mother to check in, to say, oh, is this toy safe? Should I do this? Sometimes you have to say to a mother, look how important you are to this child. Often mothers I see minimize that. They don't give themselves credit for this privileged position that they're in, that you are this child's sun, moon, world. You are this child's universe. Well, guess what? Often the mothers we see have never felt that way in their lives, either with their own family units, with their partners, with the way, and this goes back to some of what we've all been taught, and Kathy's not here, but the way people have been treated, right? That you don't walk into the office and people say, we're so glad, we hope we do this, but we're so glad you're here. We want to see you and this beautiful baby that you brought in. Do people often experience that? Or even to be told, what a great baby you have. What a beautiful baby. And look how that baby's looking at you. Lynn's always saying this. They're looking at you. They're not looking at me. They're looking at you. They hear your voice, and that's who they turn to because that's how important you are to them. Okay. So, and this is what I was, the little example I gave. I wonder if he keeps going back to you to find out whether you feel it's safe to explore that no choice. Even something that basic can really elicit so much in terms of what I was just saying. So, facilitating improvements in caregiver giver behaviors. We want mothers to be able to tease apart their own underlying emotional needs. We want to identify intentions driving their own and their children's behavior. We want to explore representations that might be limited or distorted. As I was saying, just a very basic distortion can be, how important am I to this child? You know, does this child, you know, sometimes I think this child doesn't like me, always crying. And again, to be understanding children's behaviors from an attachment perspective. So those are some thoughts we'll leave you with, and we're very happy to answer any questions or thoughts or comments you might have, or if you want some examples, please, Lynn, come on up here, and we can take questions or comments and reactions.
Do we have any questions? Reactions, thoughts?
I'm just wondering your perspective. Like sometimes when it comes to like getting the child to sleep in a crib, parents are told maybe like ignore the crying so then they will learn to sleep in their crib. And there's other examples of that. And I'm just wondering, what are your thoughts on ignoring that behavior since reacting to the behavior is usually positive?
Well, I'm sorry you asked that question because I'm very interested in infant sleep, and I would be very happy to stand here all afternoon and talk to you about infant sleep. I think, you know, I think maybe what you're alluding to is the cry it out method. That's not, so first of all, I would say this. If that method is going to work, then I'm not going to be seeing that family. Okay. The people who come to see me, and I can tell you, I just talked to someone on Friday, and I'll just tell you this, and you can tell me how old this baby is. Okay. Baby's nursing every 2 to 3 hours during the day, up at night. And during the day, the mother is holding the baby most of the day. The baby wakes about every 40 minutes at night. How old do you think that baby is? 10 months. I didn't tell you the baby, she started the baby on solids. I left that out. But the baby's getting solids twice a day. You can imagine the mother's talking to me. And she's a first-time mother. She's had some loss. She had a very difficult pregnancy. Am I going to tell her just leave that baby and try to cry it out? No, never, never. And so, you know, you have to start where people are. And so this mother is worried. Well, she's worried about a lot of things. And it's a family that you wouldn't consider high risk, meaning they have they have a very, anyway, they have good jobs. They have, you know, a lot of support, on and on. Anyway, I try to start where the families are. And again, I have to understand the mother. I have to understand what the mother's wanting, and I have to try to understand the baby too. And so this poor woman who is exhausted, she hasn't been able to go back to work. And she's calling me. You know, I don't usually do calls, but but anyway, she was calling me she's concerned about what's happening between 7 p.m. and 7 a.m. But with her, I started with, let's look at 7 a.m. to 7 p.m. because how can you put the baby down at night when you've been carrying her all day, when you've been nursing her all day, and then at bedtime expect her to be a good sleeper? So I said, so my recommendation started with let's do some things during the day. Because first of all, I think it's unrealistic to expect that things are going to change first at night. So how to make some changes during the day that are going to be successful and that are not going to be overwhelming for the mother or the baby. Anyway, I'm rambling on, but did I answer your question? Or are you sorry you asked it? Just sorry you asked it. Anyway, ask Lynn a question. She'll be more succinct. She'll be more
Okay.
succinct.
Hello, my name's Michelle. I'm a nurse with First Connections Family Visiting Program. My question is just something I've observed when visiting, particularly babies that are in foster placement. I've had foster parents express concern after visitation with the bio parents and how the baby is fussy for hours on end, and they worry, are the parents giving the baby something that makes them distressed? And actually last week it came up. I'm like, I'm wondering if this is kind of a trauma response that the baby is experiencing. And so I'm wondering what your thoughts are on that, and then how we can help support the baby and those families in that situation.
Okay. One thing, this happened to me a long time ago, but late in my career, where one thing I realized, I was talking to a foster mother who was going to adopt this baby. The child was close to 3. And the little girl would go visit her father at the library, a supervised visit, and really be very upset before, during, after these. But one of the things as we were talking that we realized that again, it seems so obvious, that was the only thing this child did that didn't involve her foster mother. So part of the piece is when you think of how these visits are constructed, often the primary attachment figure has nothing to do with them. I'm not saying always, but in my experience, most of the time. And so the baby is going so even you say, well, the child's in daycare all day. What are you talking about? But again, the parent has something to do, right? Doesn't the foster parent takes the child, or someone in the household takes the child? So we set these visits up in a way that I think don't take into account that even though this is a family member, to the child, the person is a stranger, or a new person, or whatever you want to call it. And often, not all the time, but just in terms of logistically, they may be getting a different person. So you're in a different car seat. I mean, I see, well, she just turned 4, but I started working with her when she was 2. Her car seat was very important to her. Her being in this, let's say, this red car seat, that was her seat. And you better not try to put her in a different car seat. Now, she was an older kid, so she was very verbal. She could tell us that. She could tell her grandparents, who subsequently adopted her, that. But even things like that, you're in a different car seat, you're in a different vehicle, you have a different drive. Where are you going? Where are you going? What are we doing here? So I think it's a disruption in routine. And sometimes, again, I don't know how the visits are scheduled. I would imagine there's a sensitivity to what the child's schedule is like, but it's a disruption for this child. I don't think that the biological family are doing anything wrong. I think, again, it's a systems issue in terms of how, again, we just expect that the baby is going to go, and this isn't going to be impactful for them. All these different experiences without the attachment figure there to kind of help yeah, this is safe, or yeah, this car is, we can go in this car. It's different. And it's a deviation for them from what they're usually experiencing.
And the only thing I want to add is thank you for recognizing that and processing that with the caregiver. Thank you.
We have time for one more question, if anyone has one. Okay.
Thank you. I'm a student at College Unbound, and my project is advocating for more recovery homes for women and children together in the state of Rhode Island. And I'm just wondering, wouldn't it, based on the information given, particularly one statement was the developmental outcomes of keeping babies and moms together. I guess my question is, wouldn't it make more sense systemically to provide more recovery homes together? I know we have Starbirth, but we have Starbirth, one Starbirth.
Right. Absolutely agree. I do think it would make more sense to have more of that.
And do you know about the Amos House on Brownell Street? Yeah, they're right. They're a stone's throw from our office. So yeah, but absolutely. Some places they have tried this, and honestly, I don't know much about it, but some places have tried a foster home where the parent goes with the child too. So, people are trying different things. Years ago when we were doing a study, the IDEAL study, looking at methamphetamine use and child developmental outcomes, one of our sites was in New Zealand, because a big meth problem there at the time. And New Zealand unequivocally does not remove children from their parents. And there's substance use. I mean, there's big substance use there. But that is their point, their starting point, is they do not remove children. Okay.
Thank
Thank
you
you.
both so much.
Thank you.
Big round of applause.
I'd like to introduce Ruben Cottrell. Ruben is from Massachusetts. You can read his bio on the through the QR code that we provided, but I just want to let you know that Ruben came and he spoke to the Perinatal Substance Use Task Force maybe a year ago, a little more than that, on fetal alcohol spectrum disorders. Here in Rhode Island, we've had 0 reports of FASD to the Department of Health in at least the past 8 years. And yet we know that pregnant women are drinking alcohol. Especially during the pandemic, those numbers really soared. So it's a really important thing to talk about to help you as providers, people who are taking care of pregnant people, intentionally being sensitive to screening and really understanding what fetal alcohol spectrum disorders are and what to look for to mitigate problems down the road for kids. So please welcome Ruben Cottrell from Massachusetts, FASD.
Hello, everyone. So I took that picture yesterday. It is an absolute honor and privilege to be here. I love Rhode Island. You have better beaches and a lot of great food, and so I'm always happy to be here and really grateful to be able to experience this conference too. All right. So, as Margot said, my name is Ruben Cottrell. I am the FASD Services Coordinator. I'm going to start saying FASD because fetal alcohol spectrum disorder over and over and over again. It's going to make my mouth extra dry and you're going to get really sick of hearing it. So, I'm the FASD Services Coordinator for the Mass FASD program at the Institute for Health and Recovery. And today I'm going to be talking about supporting people and families affected by FASD. All right. So, a little bit about my organization, the Institute for Health and Recovery. If you're not familiar, which I'm sure most are not, we are a nonprofit in the state of Massachusetts. Essentially, we have two arms to our services, one being referral and counseling services, which is all outpatient, and that's specific to my state. Um, but we also have our training, technical assistance, and consultation, where we support all kinds of folks through the lifespan, professionals primarily, but as well we support families and individuals who are impacted by substance use, trauma. We do crisis response and prevention and so on and so forth, and that is applicable here in Rhode Island. And so my program, Mass FASD, falls under that training, technical assistance, and consultation side of things. And so we are actually funded directly by the Bureau of Substance Addiction Services, which is through the Department of Public Health. And so what we do is kind of a wide range of things. We do trainings like this, or at your programs that you work at, or in your communities, foster parent groups, or kind of whoever wants to learn more about FASD or have some different conversations. We also provide general resources. You know, we do that technical assistance piece. If you want to reach out to me and you say, well, your presentation was really interesting. I want to learn how cannabis interacts with pregnancy. Say, okay, absolutely. And send you like 10 different things and try not to overwhelm. And then also we do consultation, and that can look like a bunch of different things. That can be general, you know, one-on-one case consults. That can be team consults. We can hop on multidisciplinary teams depending on the case, depending on the situation. And then we also do organizational consults. So if your organization is like, oh my God, I just heard this guy talk about fetal alcohol spectrum disorders or FASD for quite some time. We don't talk about this. Pull us in, we'll give you some resources, we'll help you in any way we can. Additionally, we have a task force, and this task force is similar to the perinatal substance, meets every month, and it's just to get our professionals together around FASD. And then lastly, but definitely not least, is our caregiver support network. And that's the thing I'm probably most proud of, even though I don't oversee that. My colleague, Kristen Erickson, who's not here today, is a mom to twins with fetal alcohol syndrome, and she oversees that. We do 2 support groups a week for caregivers impacted. We do events for our families. We do all sorts of good stuff. And of course, exploring diagnostic options and general resource navigation. And that is just a cute picture from one of our events. I like sharing that because it's adorable. We have an apple picking event every year on FASD Awareness Month. And I will say the other thing I'm very proud of is we have a really good mix with our families of biological families, adoptive, foster, and kinship, which can be tough sometimes, as you all know. All right, so today our goals here, first and foremost, by the end of the session, is for all of you to be able to describe FASD and the diagnoses under its umbrella, acknowledge the need for FASD and support within the health and human service space, and then lastly, and generally, be able to apply this lens, kind of FASD informed lens within your practice. All right, so now I'm going to ask a few quick questions from everybody. I know it's after lunch. We're all exhausted. I just ate. Now I'm all tired. My mom always said I was loud, so I'm going to try to bring that to the room right now, a little bit of energy. So by show of hands, I'm going to ask 3 questions. So if this applies to you, please raise your hand if you're able to and want to. Sorry to the folks who are virtual, but raise your hand as well. So the first question, if you feel that you are very familiar and have a firm understanding of fetal alcohol spectrum disorder, please raise your hand. Awesome. Thank you. All right. Second question. If you feel you have a decent, semi-moderate understanding of FASD, please raise your hand. All right. Awesome. Thanks, everybody. And then lastly, if you feel you're less familiar or have really no understanding of what this is, go ahead and raise your hand. No shame, no embarrassment. It's all good. Thank you. All right. So to everybody in this room, No matter who raised their hand or not, if you raise your hand in the first two, you are out of the norm. If you raise your hand in the last one, that's okay. And that is actually the norm, unfortunately. So to all of you, welcome wherever you're at. One of the big things that I say when I talk about this disability is that not only did I not know about it when I was working in kind of general substance use and mental health spaces, but doctors who I speak to in the capital of medicine, which is Boston, right, or in Rhode Island, which is a real hub of medicine, legislators throughout the country, all sorts of folks do not know about this disability, and those who do don't really know a lot of the up-to-date information. So again, welcome to everyone, and just like we do with clients and and families that we work with, I'm here to just meet you all where you're at. All right, so now begs the question, what is FASD? This is a lifelong full body and brain-based disability that occurs due to prenatal alcohol exposure. And that's exclusively due to prenatal alcohol exposure. There's definitely some implications that someone mentioned earlier about epigenetics, where, with the fathers that might be relevant in the future, there's ongoing studies, but really it only happens when there's drinking during pregnancy. And so a couple things I want to highlight from what I said. It almost sounded like an oxymoron when I said full body and brain based. It is absolutely a full body condition. With that said, it's a brain based disability. And so the behaviors, the symptoms, and all the characteristics that folks with this disability may exhibit are therefore unintentional, right? And that's important to remember when we're talking about disabilities. And then the other thing that I mentioned was lifelong. So the reason I say that is because often when I tell people what I do for work, especially folks who are not in this room, who don't know this work in general, they say, "Oh my God, you work with babies. That's so cool." And I always have to respond. It's like, no, well, no, I don't. I mean, I actually barely work with babies. I wish I did more. But regardless, this is a lifelong disability, right? So when it first occurs in pregnancy, that carries the individual through the lifespan. And so when I talk about stuff throughout the presentation, I want you to think about the parents, I want you to think about the grandparents, and I want you to think about, of course, the kids as well. And FASD, as it said in the end there, is not a clinical diagnosis. That's due to lack of standardization across the field, something being worked on, some exciting legislation passed this year, actually. All right, so I'm going to talk about FASD as an umbrella term, which is what I said earlier. So a couple things to think about when we think about an umbrella term is that this means this kind of the overarching term. And so there's a few diagnoses that we're really going to look at. There's some other ones that I don't feel are as relevant to talk about today. First and foremost is fetal alcohol syndrome, which I'm assuming folks in this room are probably most familiar with. And the reason for that is because number one, it's the oldest diagnosis of the ones that we'll discuss right now. And part of that is because of any kind of physical factors. And so, as you all know, when people can see something, they can better understand it. And so when I talk about substance use disorder or mental health, that's something I always say is people have a really hard time understanding what they can't see. And so with fetal alcohol syndrome, there are some sentinel features that are associated. Those are the palpable fissures. I'm going to show a picture shortly too. The palpable fissures, the smooth philtrum, the area between the nose and the upper lip, as well as a thin upper lip, microcephaly, a smaller head circumference, abnormal brain structure, growth deficits, and so on. And so again, people can see this, it makes a little more sense, and that's why it was diagnosed early on. And then, of course, the cognitive profile associated with the disability and a history of exposure. Similar to that is partial FAS, which intuitive in the name, will have some of those features, but not all of them, but it will still have that profile and the history of exposure. But what most people don't know are that these two diagnoses only make up about 10% of the FASD population. So that means the vast majority, and we'll talk about prevalence soon as well, the vast majority of people with FASDs do not have any physical identifiers that can differentiate them from you or I or anybody else, right? And so with that, two diagnoses that we talk about, one being alcohol-related neurodevelopmental disorder. This is ARND. This is something that you may see with some older folks. You don't see it as much anymore. It is still diagnosed in certain areas, but this is one to look out for. And then the last one there, which is there's a lot more work being done on, and it's the only one that's in the DSM-5, and there'll be some updates in the upcoming DSM-6. This is neurobehavioral disorder associated with prenatal alcohol exposure, or NDPAE. Right now, it's kind of like an NOS, or non otherwise specified diagnosis, but the reason I flagged that is because it's in the DSM, so that you can be aware of it. And if anyone in here that's relevant to you, reach out. I can get you some good information on that. Those are those features I was talking about. Here you can see the kind of smaller and rounded eyes, the smooth philtrum between the nose and the upper lip, and the thin upper lip as well. All right, so a couple of things that I always talk about when I'm talking about FASD, before I really get into the meat and potatoes, are trauma and stigma. And I actually complimented, if you're in here, the people out there who have that table that says stigma, 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 and then the lines through it, because I found that to be just absolutely amazing. I mean, I talk about stigma with kind of all parts of the field, but as you can imagine, when we're talking about substance use disorders in the field, stigma. We're talking about substance use in general. There's stigma. When we talk about the impact of substance use from a parent to their child, there's even more so. One of the pieces that gets missed a lot with trauma, which I know it's a kind of a buzzword these days, but it's an important thing. You know, a lot of trauma-informed care is around classic traumas, right? But one thing when we're talking about in this community, which you're probably all very familiar with, but I always talk about it, are the three categories. And the first that gets missed a lot is that initial intrauterine insult. And so that's when the alcohol is exposed during pregnancy. So that's that first layer. And so that is the layer of trauma that impacts both the parent and the baby, right? And so we know that even before birth, there is a layer of trauma there that's relevant physically, cognitively, or otherwise. The next one is early neglect and separation. And I'm going to, in short, this one is just showing us how, and this is where you all come in much of the time, but in short, this really is represented in a way that I like to use for an example. When folks go overseas to what they still, in some places, will call an orphanage, we'll see in the infant room or the baby rooms that there's no crying happening. And the reason for that is because when the babies cry and nobody comes, it teaches them to quickly adapt, and they now know not to cry. And I know this is not necessarily a new concept for everyone in the room, but if that's something you haven't heard before, I hope that you can take that with you, because it shows us how quickly as humans from zero to now, how we adapt to our trauma, right? And how it can impact us. And then, of course, classic traumas, which can be anything from abuse to witnessing violence to, stuff that's relevant right now. I mean, throughout the world today, here in Rhode Island, stuff that's been heavy in my heart. And then, of course, just general kind of life. It's traumatic. So just thinking about that with the folks that you work with. And then, as I mentioned, stigma. A couple things to think about here. Number one, FASDs are never going to be 100% preventable. And that's not to say prevention is not important, but that happens through education, community awareness, and kind of just that holistic approach. And so they're never going to be 100% preventable, and that's for a lot of reasons, but to address them is still important. Additionally, there are a lot of reasons as to why people may use or misuse substances throughout pregnancy. And so some of those reasons are lack of resources, health disparities across demographics, misinformation. We still have doctors right in Boston in the same hospital, some of our champions who are still saying, to folks who are not dealing with harm reduction, they'll still say, 1 glass each trimester or 1 glass during the 3rd trimester is okay. And these are things that are actually detrimental because it's about proper education, not about hurting someone or harming them by what they may be doing, but really providing the necessary education for them. Of course, substance use disorders, mental and physical conditions, the influence of friends, family, and culture. There are certain cultures where cannabis use Alcohol use, tobacco, nicotine use are normalized in any phase of life that can include pregnancy as well. Traumatic and abusive relationships, of course, that can be friendships, familial, romantic, and so on. And then lastly, but definitely not least, is unplanned pregnancies. And that was mentioned here today a couple of times. And I'll emphasize that because around 49%, they say 49%, around half of pregnancies are unplanned. And that's important for a lot of reasons because the first 6 to 8 weeks, give or take, of pregnancy, someone may not know that they're pregnant. Most of the time, they will not, right? And so we get calls from people who are not trying to get pregnant, who may even be on some kind of birth control or using some kind of contraceptive. And with that, they still may get pregnant. And so we get calls from people who are not substance dependent. I'm a big advocate for harm reduction. I firmly believe in it. But for those who are not experience any kind of substance use disorder, they give us calls and they say, I went on vacation, I used cannabis, I used cocaine, I drank alcohol while I was on vacation, right? And they weren't trying to get pregnant. So that's very relevant. And then people who are told that they're infertile and they're able to still conceive through a variety of different methods. And most importantly, just recognizing that with all this said, there is no safe amount of alcohol. There's no known safe amount of alcohol, but there are a lot of reasons as to why people still will use alcohol throughout their pregnancy. All right, so now talking about prevalence, this is a really important piece, and actually, I always like to emphasize this one. Excuse me. So the first piece of data I'm going to give, it blew me away, and this is actually the reason why I jumped into the role I'm in, coming from, I mean, I experience with FASD and exposure, but wasn't something that was talked about a lot. And so I found this study that we talk about a lot in the field. In 2018, there was a study that was published by Philip May through UNC Chapel Hill, where it was conducted by Philip May. And so this study, where there was first graders, excuse me, across the U.S., across different areas and different regions, so rural, urban, and suburban areas, where over 6,500 first graders were screened for FASDs. And of those 6,500, they found that the most accurate who met the criteria for FASD was around 1 in 20. So that's what blew me away and kind of brought me towards this work, because understanding that it's barely talked about yet, this is 1 in 20. That's 1 in every classroom, 1 in every residential setting, 1 in every room you're in, right? And I think that's very important to recognize. I mean, it's even 2.5 times more prevalent than autism, which to me was mind blowing and I find it very important. It's not to dismiss that work by any means. You know, we have relationships with that community as well. But I think it's important to recognize, because of the stigma here, that's why it's so under-recognized. And of those who met that criteria, only 2 of them in the study had a previous diagnosis, right? And that's important too, because we can see how under-recognized, underdiagnosed, and likely misdiagnosed a lot of these folks are. Additionally, around 70% of kids in foster care are affected by prenatal alcohol exposure. I was sitting at a table with folks who are working in child welfare. I know that it's a lot of this room, right? A lot of us don't think about that. And the opioid epidemic is extremely important, and I'm glad we're recognizing it as a nation, and definitely in New England the way that we are. But alcohol, unfortunately, because of how legal it is, gets overlooked a lot, right? Around 80% of children and adolescents in FASD, around 80% of children and adolescents with an FASD were at some point in a foster or adoptive setting. Around 80% of people living with FASD experience some level of incarceration. FASD occurs in the juvenile justice system around 40 times more often than with the general population. I have a lot more stats if you're ever interested, especially about the juvenile justice system, because it is out of control. And again, it's not recognized. And this is something that is relevant here. It's relevant in Canada. And I mean, I think this is something just to kind of give you the scope of what's going on here in the U.S. and especially here in Rhode Island. I think Margot emphasized a really important point where there's no documented there was zero documented cases, right, to the Department of Public Health. And that's something that shows with how prevalent this is that we need to start addressing and thinking about in our work. And so, as I said before, this is underdiagnosed for a lot of reasons, being stigma, of course. Alcohol is not only legal, but it is extremely normalized. When you go to a bar or a restaurant with folks and you get offered a beer or a glass of wine and you say no, unfortunately, you're the weird one in that situation. And that's something I think we all know very well. As I just mentioned, missing necessary documentation and screenings. And Rhode Island's not alone in that. That's across the board throughout the US. There are very few states that have truly addressed this in its entirety the way it needs to be. And there's always more work to be done, of course. But when we see that documentation and we see it available and we have the history of prenatal exposure, we can then help to better support the individual who's impacted as well as the family and parents and promote better unification throughout the family. And then again, as I said, only 10% of people will have those facial features. So the vast majority, you won't be able to see this disability in them, or see it. And so that leads to a lot of missing diagnoses. All right, so now looking at some of the characteristics. In one of the methods used to diagnose FASD, they really look at 10 brain domains or developmental domains. And so these are attention, sensory, cognition, language, memory, affect regulation, executive functioning, motor skills, adaptive, neuroanatomy, academic achievement. And you'll have these slides. I know it's a little small there. The reason I even read them out is just so that you understand the areas that are most important to look at. Although with FASD, they most frequently will see deficits in 3 areas, which are sensory, adaptive, and executive functioning. Most people who receive this diagnosis will, in fact, have deficits in all 10 areas. And to put it into easier language to understand, some of the more primary characteristics that we see with FASD are slow processing, memory problems, which is a big one, although this is not categorized necessarily as a brain injury. When alcohol occurs during pregnancy, the one thing that we see on a fetal development chart that's kind of consistently developing is the brain and the spinal cord, right? So when we kind of use this example a lot. When nurses see a baby that has any kind of malformation or issue with their ears, they instantly say, okay, we have to check the kidneys to make sure that they're safe, because the timing of exposure is very relevant to what potential deficits that someone may have if they have an FASD or if they're prenatally exposed. And so memory problems is a big one because of that cognitive factor. Sensory differences, that can be the lights in the room, the tag in the back of your shirt. I always say everybody has it. Obviously, this is to a different level if you're familiar with autism or any kind of neurodevelopmental disability. I don't like a tag in the back of my shirt, but I don't feel like I'm on fire when it happens, which is, I would say, the biggest difference there. Impulsivity is a big one. This can look like a lot of different things. This can be, it's not, I quit smoking and I had a cigarette, or I'm on a diet and I had a piece of chocolate. This is consistently leaving against medical or clinical advice. This is getting into fights or altercations on a regular just because that's what your brain tells you to do, no second thought. And these may all sound very familiar to you, right? And the reason for that is because they may have been FASD. They may have been other things too. But they very well could have been FASD, and that's kind of where my brain was when I learned about the prevalence. This impulsivity can also look like over-sexualized behavior. That's one that there's a lot of issue, of course, with, but I've also seen that curbed very quickly when met with appropriate intervention by professionals who are trained, right? And I think that's also important to recognize because that puts them in a box, just like the stigma of substance use does. So these two kind of go hand in hand. I'll just say rigid thinking. And what I mean by that, and of course it's not across the board, but this is a pretty general one that we see a lot. I've heard my coworker, when she says to her kids, she'll say, "Oh, hold your horses, stop, take a second, hold your horses, and they'll say, Mom, I don't have any horses. We don't have a horse. What are you talking about? Right. And I think that's a, kind of a good example of how rigid the thinking can get. Sometimes it's just, I don't understand sarcasm so well, so it looks different for everyone, of course. Language and communication's a big one. I'll talk about that a little more shortly, but the reason why I have that in here is because not only are there often deficits in receptive and expressive language, but it's one of the most distinguishing things about FASD, and it really helps to differentiate it from other disabilities. And the reason for that is because their expressive language will often exceed the receptive. So I know some self-advocates with FASD, some may not, but some will be up here talking to you far better and far more articulate than I am, right? But when it comes to the conversation, that kind of one-on-one setting, being able to understand and really take in that information, that's where the difference lies, and that's where they end up a lot more victimized than most. And then lastly, I have dysmaturity. And the reason why I have that there isn't because it's necessarily listed as a cardinal characteristic, but I like that term. I've been in a lot of clinical settings and I've heard a lot of professionals who are really good at their jobs say, oh, well, that one's immature. Why are they acting out in group or so on? And so the big difference, of course, is that with immaturity, it's that they won't, where with dysmaturity, it's brain-based, right? So it's that they can't. And I like that word, so I'm going to give it to you today. And so those were the primary characteristics, but additionally, and I'm not going to go over every single one because I don't think it's necessary, but you'll get the picture. Here's the secondary and the tertiary characteristics. And those secondary characteristics, we're looking at frustration, low self-esteem, and so on. And so those are kind of the short-term characteristics where let's take, for example, to just relate it, when you see a kid in school who has, some kind of mood disorder or, ADHD, and you kind of see them acting out, but getting met with a punitive response or not getting met with any kind of support or accommodation, what happens? They get very angry. They get upset. They don't feel supported. They don't feel recognized. They don't feel heard. And so that's where all that stuff kind of builds in the interim, in the short term. But what happens later on in those tertiary characteristics, or as we call them, the chronic characteristics, are things like disruption in housing and foster placement, things like substance use disorders or substance use in general. Self-harm's a big one, unfortunately. And then, as I mentioned earlier, victimization. That's a huge one, right? So if you come off like you're a peer to someone, if you come off like you're neurotypical, whatever that may mean, if you come off like that and you're talking to someone and you end up in a situation where developmentally, let's say you're 10 years old, but you're a 20-year-old, person, and you end up in a situation where there's a crime committed, and a cop comes up to you or a police officer comes up to you and they're really pressing and they're saying, what did you do? What happened? How do you think you're going to respond, right? That's where survival instincts come into play. That's that fight, flight, freeze, and fawn. And that last one, that fawn, is very relevant with FASDs because they'll be the first ones because they're so expressive. They'll communicate well and it'll come off like they understand it. They'll repeat, they'll parrot, and they'll say stuff like, yes, officer, that was me, right? And then they'll end up having to do the same thing with a public defender or an attorney. And then they get into the courtroom and they're being asked these questions by this individual who, I'm sure many of you have been in courtrooms with clients who are very aggressive at times, who are very confrontational, and who are very fast. They're asking a lot of questions. And so that victimization is a huge piece. All right. So now just quickly looking at differentiation and identification. Some of this I could go on for an entire day. I'm more than happy to. If anyone wants to call me later, we can go back over it and talk more. But just some key things to think about here. So I have that little alphabet soup picture. I love that thing. I don't know where I found it, but I use it all the time. I hope it's not AI. Not that there's anything wrong with that, but I like that one. And so that alphabet soup picture, the reason I have that is because when you think about whether it's your place to diagnose, whether it's your place to screen or not, the folks that you work with advocate for or yourselves and your family, right? When people are looking at them, they're seeing ADHD, they're seeing autism, they're seeing bipolar disorder, they're seeing all sorts of things. And at the very bottom of that list in that alphabet soup often is FASD, but it's overlooked, it's not seen, and it's way too low in that bowl, right? And so I find that to be very important, but that's not to say those other diagnoses don't exist. They may or may not, depends. But a lot of the time when FASD is the root, it's something that you can address first, and then, of course, along with the other conditions, address them as well. And so there are 428 co-occurring disorders, or co-occurring conditions, excuse me, with this disability. And the reason why I say 400, I emphasize the 428 in that sentence is because that's a lot. Again, some of those may be given as misdiagnosis or as the primary diagnosis. So that's helpful to recognize. Around 90% of people with FASDs are estimated to have mental health conditions. I actually think that's pretty conservative as an estimate, and the reason why I say that is because a lot of that's looking more at kind of those predisposed conditions, whereas we all know conditions like that can always develop as time goes on, especially with some level of misunderstanding. And so some other things to think about are, as I mentioned earlier, are those deficits in executive functioning, adaptive behavior, social skills and communication, as well as that sensory processing piece. And just like kind of a lot to think about, but just to know that with those, like, and even thinking about when there's an NOS diagnosis, giving a clinical diagnosis, like I mentioned mood disorders. If there's a mood disorder NOS, right, maybe considering thinking about the bigger picture where FASD may be relevant. And then I wanted to just mention, I know I kind of went over it already, but that language piece is so huge. And the reason why I go over that again is because when someone has the ability to communicate well and they can really repeat and parrot conversations, if you ask them, do you understand me? They very well could say yes, and most of the time not mean it. Right. And so that's why asking, can you put that in your own words for me? And questions like that are really important. And not to say many people in this room don't do that, but there are a lot of people who don't know to do that, especially if someone's presenting in a certain way. Another couple things that I want to mention, I mentioned memory problems. One of the biggest terms that I like to throw out is confabulation. Raise your hand if you've heard the term confabulation. More than usual, and that's great. If you haven't, that's okay too. So one of the easiest ways to explain this is when you have those memory problems and those processing issues, what happens is it's kind of perceived as lying, but really it's filling in those gaps in memory. And so a lot of times what I mentioned in the beginning, which is the behaviors and characteristics are unintentional, they're not lying. They will truly believe what they're saying because that's where the confabulation happens. That's where the gaps are being filled. And so those are, to them, evidence and fact and truth, right? And then additionally, can everyone who's heard of the term anosognosia raise your hand? Don't, not all at once. So that's also a great time. I'm giving you good stuff to walk away with. Like you can go home and be like, "Hey, I know about anosognosia now," right? Sound like my doctor. So anosognosia is also very important because that's a condition. This is a often co-occurring condition with FASD and with stuff like bipolar, schizophrenia or schizoaffective, Alzheimer's, dementia. And you'll see it in a bunch of different conditions that have these paralleled kind of brain similarities, right? Brain differences. And so what that is a condition where the individual does not know that they have it. That might be that they truly don't know that they have the entire condition or specific symptoms around that condition. It can look like when we see that kind of cycle of psychosis occur, right? Medicated, stabilized, that didn't actually happen. You might hear that from clients who experience some of those things, manic episodes, right? And then they get stabilized, take their medication. That didn't really happen. I don't really feel this. I don't need this. Stop taking their medication. The cycle continues. So it's kind of an easier way to think about it, but it is a real condition. And then I also, this is a really important piece. So I kind of talked about what this is, what it can look like, some distinguishing factors. But an FASD informed approach is kind of the key to this talk right now. And the reason I say that is because what we experienced all together, it was my same experience when I first learned about FASD, which is that most of us in society, but more importantly, most of us in the field don't know that much about this. So now that you have a little more of an understanding of it, and hopefully, reach out if you ever want to learn more, but hopefully even on your own, you look into it a little bit. So now what my hope for all of you is to be able to come at things with this lens, knowing that this is common, knowing what some of these differences are, so that you're able to understand, as I said, that these behaviors are not only unintentional, but when we implement any kind of strategy that's relevant or focused on this disability, just like anything, right? No doctor that I know is going to treat someone for cancer when all they're showing is signs of a cold, right? And I think that's important because when we individualize care, that means that we're able to support people and really meet them where they're at. So a lot of the time, people with FASDs will be given services that honestly lead to regression a lot of the time, which is not ideal with such a high prevalence. And then similar to that is I mentioned these kind of three categories and of characteristics, right? So similar is really understanding a neurobehavioral model. And that's taking the primary characteristics that we talked about and separating them from those secondary or even tertiary. Because what happens is when we see a certain behavior that could be natural or some that could have developed due to that misunderstanding, if we only look at that behavior, then we're missing what's underneath, right? And again, I know this is probably not a new concept, but it doesn't happen as often as you'd hope or you'd think. So when we do that, it gives us the opportunity to really look at the underlying features. And with FASD, this is the primary way to think about things. So the result or the causation and then the result. And I think, one of the things I talk about a lot is that yes, those secondary and tertiary characteristics cannot be eliminated, but they can absolutely be decreased, right? And then this is an important thing for folks in this room and I think in general. This is relevant to people you know. This is relevant to your work or friends or pretty much anyone. Coming at this conversation when you're talking to a caregiver, whether that's a biological caregiver, a parent who you're working with, a foster parent, adoptive, kinship caregiver, coming at this understanding again that kind of trauma that we talked about earlier, the stigma that we talked about, and knowing how to start the conversation. Because I can guarantee everybody in this room without needing to back it up, I can if you want, but without needing to back it up, if you ask someone that you're working with, especially someone new, did you drink while you were pregnant like that? They will 9 times out of 10, if I'll say 9 times out of 10 because I don't want to overdo it. They will say no, out of fear, out of stigma, out of insecurity, out of shame, out of everything, right? Across the board. And so when we talk about this, there's a lot of opportunities out there for if it's relevant to your work to screen or to provide screenings, right? I think a lot of people stay in their role, which is a good thing. It's okay to be in your role. But if you have information that someone on your team or someone in your organization doesn't have about a specific condition or topic, it's good to be able to share some resources. So I have I'll share a bunch of resources after this, but I have some informed resources that are specifically for screenings and resources also to learn more about this because, like I said, when you ask like that, it's going to get a no. But if you ask questions to just kind of start the conversation and determine that potential, it allows to build trust because trust-based relational intervention and trust-based relationships are the key to these conversations. So when you ask, when did you find out you were pregnant? Or tell me a little bit about your history before pregnancy, and then kind of get to the substance piece eventually. There's a big difference when you kind of build that relationship. I loved what Amani said earlier about the doctor who just turned to the side. I thought that was great. I think that's not only trauma informed, that's a good doctor. That's just a funny person. But But that's a really good point, and that's really relevant to what I'm talking about right now is how we have these conversations, how we word things. You know, this is a field built on really strong people, but it's also a field of very burnt out and exhausted professionals, right? And we can all relate to that statement. And so being able to kind of like take a second and think about our tone, think about the way we say things, think about how we say things is going to change the way that these conversations go and the information that we can gather from the folks that we're working with. And then lastly, I just want to, oh, validation. That's a huge one. You all now know how prevalent this is. It's really easy to reassure people that this is very normal, right? It may not feel normal at first, but this is a very normal thing because it's so common. And then lastly, listening to caregivers. I've heard that term a few times today. I actually thought about that before I came up here. Is I heard the term we have to listen to people with lived or living experience. And I love that. I think it's a beautiful and very important thing. But also, just because we listen to them after the fact, after like we shouldn't be just listening to after the comeback story occurs. We should also be listening to them in the moment, right? And hearing where they're at. So there's a bunch of stuff here. This can kind of get cluttered and confusing and a little much. What I will say about this slide, about the therapeutic options, there's a lot more that goes into this than just let's get some occupational therapy, which is a key service for FASD. With that said, if someone's not aware of the disability and they're an occupational therapist, that doesn't mean they're going to deliver the appropriate service. And that's why in the bottom I said there that we need to make sure that it says avoid traditional reward-based or behavior interventions. Those have not been proven to work for this disability. But for the first time ever, actually, there was ABA services that were developed for FASD down in Florida, and hopefully that continues because it's such a widespread service and occupation right now. So with all that said, there are a lot of relevant services, but there are not a lot of adapted or FASD specific services available. So that's kind of where my team comes in a lot. That's where FASD United, which is a national organization doing this work, comes in. And there are a lot of people around there to support you if this is something that you will come across it, but this is something you identify in your work. So one thing I will say, you're not always going to have a diagnosis. You're not always going to be able to identify FASD. You're not always going to have documentation or proof of exposure. So with all that said, diagnosis, while it's important, identification and learning what it is to work with people having this FASD lens, having a neurobehavioral model in your work is really important when the diagnosis is not necessarily relevant or possible at that time. So I will say that, but a diagnosis is still important, and that's because it helps to increase awareness and understanding of FASD, helps to enhance services that we have, kind of provides a roadmap, not just for the individuals, not just for the family, but for all of us. This decreases those secondary and chronic characteristics that I talked about, and in general, just kind of helps to give better understanding of self to the individual who's impacted. All right. Last time I'm going to ask you to raise your hand unless you have a question at the end. What I'm going to ask now is who here, and I know there's one hand that won't go up, but it's okay. I'm now going to ask who here now knows more about FASD than they did before I walked on the podium. Show of hands. Right, that's good. That's great. I like to see that. I always ask that. That's not for me. That's really just to show everybody in this room. I mean, it feels good. Don't get me wrong. But it's really to show everybody in this room how much, whereas a topic like substance use disorder, I bet everybody in this room could learn something from a presentation, but in general, we know quite a bit. So that just kind of shows us how much more we can learn. So a couple of resources that I want to share. First and foremost, FASD Rhode Island. This is a very new project. It is not established in the way that you may think when I put up an awesome logo like this. But my predecessor, who created the program that I oversee, has created FASD Rhode Island, which is this basically just an opportunity for folks here in Rhode Island to kind of come and get some consultation, some general support, some information. Her name's Enid Watson. Happy to, Margot and I can both share some information about her. She's a powerhouse. She's really funny. She's a really good support when it comes to FASD and prenatal alcohol exposure work. Is anyone in here familiar with Thunder Mist? Awesome. I just learned about them recently. I'm very happy. So Enid's nephew, actually, who is a doctor, he's great. He works at Thunder Mist, and they are actually, as of today, not to say there's not more out there, as of today is one of the few places in Rhode Island, so used to Massachusetts, where there are FASD trained and informed providers who can provide medical diagnosis, not clinical, unfortunately, but medical diagnosis as well as support and consultation right here in state. So I thought that was great to know if you didn't before. FMF Connect Pro, or Families Moving Forward. This is a really awesome study being done from the University of Rochester, and it involves quite a bit of training, but this is specifically for mental health professionals, which may pertain to some of you. The people who develop this are like the rock stars of the FASD field, and I'm more than happy to make connections for you, for your organization, for colleagues. This is a great opportunity to learn more and to really develop as a mental health provider around FASDs. And then lastly, Safest Choice Learning Collaborative. Excuse me, this was designed initially for medical professionals, but this is a national organization providing a whole lot. They're out of Boston Medical Center and Proof Alliance in Minnesota are partnered, and they give virtual trainings for medical providers, specifically pediatricians, OBs as well, but also for clinical teams in general. They've expanded quite a bit, fortunately, and this is all around FASD best practices. They're amazing. It's an echo style. I've been to their trainings. Pretty phenomenal. So highly suggest them. And now I will open for some questions.
I have a question.
Shoot.
Hello. All right. Sorry. So probably since I've been doing this work for 8 years, we've probably had maybe like 30 women deliver that had drank very heavily their pregnancy, but it's all self-report, so they don't get like the diagnosis at birth, probably because they don't have features. So what is the average age after that they get diagnosed, and how?
It's a great question. So more often than not, we suggest neuropsych eval for diagnosis because it's kind of the most accurate way, I would say, to get the diagnosis. And that's where that neurobehavioral disorder associated with prenatal alcohol exposure comes in. That's a great point. And like you said, right after birth, with no physical features or documentation of exposure, you'll be able to identify it. Getting any kind of diagnosis without the history or documentation of exposure is very rare without significant context of prenatal exposure, which makes sense, right? Because we don't want to misdiagnose folks. But if there is a history and no facial features, usually we'll start seeing people presenting with some of those characteristics that I was talking about, where there will be significant differences between them and their peers between like second and fourth grade a lot of the time. I mean, of course, it varies per person, but seeking neuropsych would be the way to go about it at that point. And genetic testing is really important too. Number one, to look, because if they have partial fetal alcohol syndrome, some of those features might be more difficult to see. They won't have all of it. Oops, excuse me. They won't have all of those features that I talked about. So that can also rule out other genetic conditions as well.
Thank you.
So hi, thank you so much. This was an awesome presentation and well needed. But I would also like to talk about prevention. we're not educating the ladies. And if we do, then we can do some prevention. And I'm not hearing that education happen. In fact, about 6 or 8 months ago, I was doing a training for some recovery coaches and doulas, and one of the persons in the training said to me, I'm not sure, but my woman that I'm working with asked the nurse practitioner if it was okay if she had an occasional glass of wine. And the nurse practitioner said, sure, you won't get in trouble. So, I mean, we'll wait for the disease to happen, but we can do some prevention. I'm not hearing a lot of education to women. And when women know that this may cause harm, one drink is not safe anytime during the pregnancy, I think we're missing the boat on prevention here.
Yeah, that's a great point. Thank you for saying that. And I want to circle back with that statement because I appreciate that. Earlier when I said, you know, this is I believe in that we have to support the people who are living with this, right? That's very important with the families who are impacted. But with that said, that doesn't dismiss the importance of prevention. I earlier said this happens through education, community awareness, which is true. But in the state of Rhode Island, like the state of Massachusetts, like many other states, we don't have warning labels everywhere. We don't have information about this in doctors' offices. We are still telling people, and as scary as it is, we are still telling people it's okay and it's safe to drink X amount. Again, there's a big difference between harm reduction and allowing or promoting folks and telling folks as medical providers that it's safe to do so. And so I absolutely agree. And I think prevention messaging, I mean, that kind of top down, unfortunately, that's a lot of policy related things, but it's very doable. And for all of you in your roles, I think it's also important to say that because some alcohol will not definitively cause an FASD or other congenital abnormalities or disabilities, but they're then at risk of that. Any amount of alcohol could cause an FASD or other issues. So thank you. It's a great question. It's far more prevalent is the answer. It is actually far more prevalent in Europe than it is here. It's far more prevalent. Russia is a big one. Ireland's a big one. Actually, we have another FASD subject matter expert in the room who could answer that as well. Thank you.
Thanks.
Uh,
One
yeah,
more
and that-
question.
oh, sorry.
I'm sorry.
I was just going to say, and that's really important to recognize because that's not that they're doing something wrong or we're doing something right. That's cultural differences. You know, there are areas in Canada is so far ahead with this work than we are, and they still have plenty of gaps and ways to go. So,
Okay. Thank you, Ruben.
Thank you.
Wonderful.
So we made it to the end of the day. Thank you, everyone who's still here, in person, online. I hope everyone is getting a nice little sugar push to get us through the end. Okay, so this is our final event of the day, our final offering, and thought it would be nice to end with a panel, some of our Rhode Island stars. I'm sure all these faces are very familiar to each and every one of you. When Margot and I were planning this, we wanted to really highlight at the end, you know, we've learned all day, and now let's hear from some of the people who do this work every day in this great state. So just to kind of ground us in the conversation that we're going to have. So anyone who does this work, and particularly here in Rhode Island, can tell you there are a lot of amazing services and incredible providers in the state. And while we all work together, we also often work in silos. It's one of our big challenges that I think we all try really hard to interrupt, but it happens. And I think this fact, combined with stigma that we've discussed a lot, that pregnant people with substance use disorder face, as well as their unique clinical and social needs, makes coordinated and interdisciplinary care teams absolutely necessary. I think anyone here will tell you that we all bring ourselves and our own life experiences to this work in some way. It is meaningful, complex, rooted in family histories, and a complicated legal landscape, which is made even more complicated every day with our increasingly toxic drug supply. My hope here, through people sharing their unique perspectives, more about what they do and how and why they do it, is that we will walk away from today with even more motivation and perspective on why people who use drugs and navigate substance use disorder through the perinatal period require our compassion and our creativity. As you will hear in a moment, we have an amazing group of individuals here who all work either directly as service providers or with service providers or both. I hope this will become an informal discussion where we can learn more about each other's work, ask questions, etc. So, to our panelists, I decided I like when panelists introduce themselves, actually. So I would love if each of you could please briefly introduce yourselves and the work you do, and specifically as it pertains to the population we're discussing today.
Hi, I guess I'm going first. I'm Katie Gonzalez. I am a perinatal peer specialist for VNA of Care New England. I work with pregnant and parenting people, obviously with substance use. What else is there?
The work you do.
Oh, and I just celebrated 10 years of sobriety, so.
Can you hear me? Hi, everyone. I'm Erica Oliveira. I've worked at Women and Infants for 16 years now. I've worked in women's behavioral health to some capacity in that time frame. For the last 8 years or so, I've been working as a clinical navigator, helping perinatal women with substance use disorders navigate the healthcare system. And recently, I am now the Rhode Island Maternal Resource Network Resource and Referral Specialist. I do this work really because I find that women perinatal patients with substance use disorders, when they find out they're pregnant, they find themselves at the crossroads, and it's a time where they have a lot of motivation to make changes in their lives. So I think we can help the patients really navigate that time and help them and really lead them to, a path of recovery and healthy outcomes for the patient and the baby.
Should be on.
Hi, I'm Mary Beth Sutter. I'm a family doctor, and kind of a brief explanation of what it means and what I do, just because it's not entirely intuitive. But so I went to med school here. I trained here for residency, and then I went on to do a fellowship where I learned additional obstetric skills, and that was out in New Mexico, and that kind of gave me a deep exposure to addiction for the first time. And then I came back here in 2019. And so I work at Women and Infants. I do prenatal care. I do labor and delivery. And I also do nursery care with Dr. McNamara. And so we admit all the babies of the family docs of the state. And so that includes like Thunder Mist, Blackstone Valley Health Center, people from all over. And we take care of their babies too in the nursery. And a lot of times that will include babies of moms who are on Suboxone or methadone and in sustained recovery, like with Thunder Mist. Beyond that, I do primary care as well. And I have quite a few pairs, like moms and their kids, that I still take care of. And sometimes we meet prenatally, luckily, sometimes we meet afterwards. But I'm always happy to take more of those pairs in my panel. And I will say it's one of the most rewarding things I do when I can see a mom and a baby 6 months, 12 months out having the first Christmas together, which I'm looking forward to for one of my couples whose dad I saw in the lobby. And just that feeling is like no other, knowing that someone has made it through to the other side. And that's why it's so important to me as a family doctor to carry it through the whole way. Beyond that, I'm also a teacher. So I teach the residents at the family medicine program, and I do expose them to some of this work. And I think that's also really important to teach them how to be compassionate and how to learn some addiction care within family med. And then I also participate in some of the state committees. surrounding this work in other maternal child health. So thank you for having me. It's wonderful to be here.
Hi, good afternoon. My name is Quatia Osario. Most of you know me by Q. I'm the founder and executive director of the Urban Perinatal Education Center located out in Pawtucket. And we, of course, offer childbirth education, lactation, and doula referrals for our birthing people. And my job in this work really is to navigate the larger network of care coordination when it comes to providers, research referrals for families. When we get them, they're usually pregnant. They already are working with a worker. And so they're coming for childbirth ed classes and they have a lot of questions. We do our 6-part series, one of our childbirth educators in the room. And during that time, they're often looking for a letter of support because part of the process is also saying that they've taken a parenting class that they have to prove to their worker. And so we get asked a lot to provide letters of support to say, I've taken this class. And oftentimes they do come back. Sometimes they were able to retain custody of the baby. Sometimes there's not. A lot of the work that I do outside of the center is also working on state committees where that's where I kind of met Mary Beth, and we do that work together. But I was also a former foster parent. And so some of the children that I have were children that had to be weaned off. And so learning what that was like to navigate that system and still also trying to make sure that you're neutral. But because of my work, I also want to advocate for the parent, especially if they're doing a really good job. And I will tell you, sometimes the system works for them and sometimes it don't. Very much. And you find yourself also frustrated in the system trying to reunify this family, because I was a reunification foster parent, to be like, you're looking through a biased lens. You're not coming in really seeing the whole situation. You need to take a step back and having that conversation and then waiting for the castle worker to come in. And sometimes even the castle worker is kind of a little bit jaded. And so when you're working in the community as a provider, or you're working in the community as someone who is actually servicing this population, because being a foster parent is part of maternal health. It's not always black and white. You know, a lot of people live in the gray, and the gray is where there's a lot of gaps. It's where people get abandoned and where people's rights get taken away. And so we work with community health workers. Corinne somewhere in the room, maybe she stepped out. But anytime we had a justice assistance case where someone's rights were being violated, where they weren't receiving good advocacy, we would reach out to the CHWs in this workforce so that they can pick up the pieces that I wasn't an expert in, and they can lead these families to the resources that they need, help them navigate the justice system, help them navigate the resources that needed, connect them to other agencies and communities. Some of that were out in the lobby today, and some of you who are here in the room, to make sure that they're getting that full care that they deserve and is so needed in our community. And I don't know if you know, but I'm going to do a shameless plug. CHWs are under attack. So please make sure that you are in this legislative session, that you are contacting your local representatives and senators to make sure that community health workers stay a funded population in the community, because it's so necessary and so needed. We cannot do this work without them. They are essential and they are crucial. And honestly, at the end of the day, providers are not going to fill out that paperwork, and they're not taking those 9 p.m. or 11 p.m. phone calls when people are in crisis and they need support then and there immediately.
Yes. Thank you for that. So I feel like these terms get thrown around so much: coordinated care, integrated care, interdisciplinary care. But I'm hoping that, and some of you already kind of spoke to this, but that each of you can talk about what that means for you in your role, and who comprises the teams of people that you work with, and sort of how does that look for the people that you serve?
For me, coordinated care means collaborating different providers with different skill sets to wrap around a family. It looks different for everybody, in my opinion. It depends on like what their needs are. I would say the majority of my care coordination is with women and infants, Dr. Mac, so they could get a rundown of what to expect when they deliver, home visiting, substance use treatment. But again, it varies for everybody.
So I would say coordinated care is intentionally thinking about the programs and services that a patient needs for themselves, really, as there's no like cut and paste kind of care. It really depends on where the patient is and what's going on with them in that moment. and where they are in their journey and also in their pregnancy. As far as our team, we have a wonderful team at Women and Infants, and also within the state, we've created some working groups to really have improve interagency communication. There's a substance exposed newborn working group between the hospital, DCYF is there, also the Rhode Island courts and the Department of Health. And really our focus is on improving care for patients and also, while in the hospital and before the hospital, before they come into the hospital, how we can improve care there. And also, we have a great program at Women's Behavioral Health with the Rhode Island Moms PRN program, where really staffed by psychiatrists, psychologists, and social workers to really think about the services that perinatal patients need, any kind of behavioral health service. Any provider within the state can call the line and we can help connect to services. So we definitely encourage anyone with perinatal patients to give us a call and we can help connect your patients to behavioral health supports.
Awesome. I think that I agree with my colleagues. The coordinated care looks a little bit different for each family. I just want to say how impressed I've been with kind of our progress over the past couple of years. Like I remember coming to this conference when I had first moved back here in 2019, and I remember your very first time you spoke. It was awesome and really inspiring. And just thinking about how now I have met a lot of you in this room, and we've had meetings together. We've had our DCYF working group, which has been super powerful and something like I never would have dreamed would have happened, honestly, in 2019 or in the other states I've worked in. That was not a working relationship that I've experienced before. And with social work as well at Women and Infants as part of that working group too. So I think we are such a small state and we have so many opportunities amongst us that we can come together with communication. And I think that's what's so wonderful about this conference and seeing everybody here today. And I hope we can continue those working relationships and make them even stronger.
I'm all for care coordination. I don't like the word integration. It's a bad word to me. It means being absolved into something else. So I like collaboration, care coordination. When we're doing care coordination, it is very much individual. You want to see that person, that situation in its full entirety and not just cookie cutter it and say, oh, this person, alcohol use, or this person, marijuana use. So I'm going to make all these judgments about this individual and I'm going to navigate their care based off of preconceived notions because the situations can be different, a lot deeper, more in depth. And so I give an example. I had a mom who was coming to our center. They were taking childbirth classes. They called us with an emergency. DCYF had been submitted to their house to take the baby. This was a person who had gone to the day hospital. The story was kind of confusing about what really happened, but the police were there to take the child. The police officer in the background was saying how he was there to take the child due to emergency certification. For those of you who know, emergency certification means you can be hospitalized for 10 days involuntarily. But they were saying this was attached to the child, which didn't make any sense. Was able to get on the phone with Corinne, talking to the mom on the phone, trying to keep her calm, trying to make sure that, she kind of stayed level-headed. Corinne got to the site, was able to be there to kind of support that. We then worked with DCYF as far as the foster placement for the mom. The mom did all the things that were required. It went to court. She had representation. She was able to bring all of her information. In the end, this mom was reunified with her child. So, right, there was multiple people involved. That was a great care coordination situation. Everyone showed up. Everyone worked on a safety plan was put in place. And to this day, this mom has this child, right? And so just know it's not always going to be, in the preventative or at the moment. Sometimes it is going to be a crisis call that you have to respond to, and you have to have the phone numbers and you have to be ready, and the people that you have to be able to activate. But a lot of us also get put on hold. Part of care coordination is also caring for the people who are doing the job, right? I'm still a person at the end of the day. So I had to make sure that someone was there to watch my kids. Somebody took out my dog. This person, she was on her way to pick up her daughter. She had to coordinate somebody else. So care coordination isn't always just about the patient. It's about us as the providers who are doing the work too. We also have care coordination. I could have been in the middle of grocery shopping. Now I have to leave, run out to do this. You don't know how long you're going to be gone for. That phone call ended up taking us hours. The entire situation took us weeks, months to resolve. And so you're always in, this fight or flight, defensive, which we know can lead to a lot of issues. Burnout being number one, cardiovascular. Then we end up moving around. The weight ends up going on. Folks' skin change, hair loss, all of those things directly affect. So it's also talking about care coordination for the people who are doing the work. When is the last time you've been to the therapist? When was the last time you've had a physical workup? What are you doing about self-care? How are you empowering yourself in self-love? And when it's time to leave? Because we all know what it's like to work with people who should have left this industry long time ago. They become the problem. They need to take up crochet or knitting, do some puzzles. We need to start bringing them some fidget tools and coloring books. They need something, a whole new work field. But that's one of the things I want to make sure that when we talk about care coordination, it's also for those of us, the providers who are doing this work. If you're burning out, if you find yourself judging people, having certain preconceived notions about institutions, agencies, individuals, you probably need to question yourself, should I still be doing this work, or do I need to take a pivot? Am I happy doing this work? Am I coming in with a saviorism type of complex or something like that? Like really doing the intrinsic work to say, am I safe? You might not be a safe provider. You might be on someone else's blacklist, and that's why they will not work with you. And so checking inwards, sometimes checking your resources in your network, following up, listening to the families. And yeah, some people lie. And the story might be like, you're like, girl, why are you lying? Because I just got off the phone with such and such, and that's not what happened. But, making sure that you're doing your due diligence and you're doing the best of your ability, and knowing when it gets to a point that you are no longer a safe provider in this work, that you have an exit plan to go somewhere else, because you're needed somewhere else when you're not promoting violence in the work that we do.
I think what you're saying, Q, is also making me think about, well, first of all, we have like certain disciplines up here, but there's also other people who aren't here: social work, nursing, low threshold harm reduction, frontline service workers, etc. So I think considering all of that, I think it's interesting to think about in terms of coordinated care, like who isn't here, and also in the work that we're doing, who are the clients that are not here? Who are the people that we're missing? So I think with that in mind, what do you all think is working well in terms of care coordination, and what do you think needs to improve for in care coordination for this population, and where do you see the gaps in services?
For what's working well is I've built relationships over the years where it's like Dr. Sutter, hey, she needs a PCP, and she'll take her like next day. So I think it's like building those relationships and getting that immediate like services in place for people instead of, going through a drawn out process. And also when I started doing this work about 8 years ago, I would say like 75% of the referral source would be from DCYF after delivery or before or whatever. So now the numbers are switched. I'm getting probably 75% of community referrals before DCYF even knows about them. So I'm able to meet with them and work with them prenatally to wrap them in services to avoid DCYF from even coming out. That's been working really well. What is not working well is, I would say for pregnant women specifically, is, we all know, I think we talked about it, is lack of inpatient programs for women and children. Starbirth is my go-to, but even getting them into Starbirth is difficult because they have to be medically cleared first, and nobody will take the risk for a pregnant person. It's crazy.
You took everything I was going to say.
Thought I went first.
Again, I think really trying to engage with patients in the prenatal period is so important. We find that when patients aren't engaged prenatally and they come into the hospital, without any support service. They don't know anything about what's going on, what's going to happen when they come into the hospital. We've really missed the opportunity to kind of help them and put protective, preventative things in place to be able to support the family. So I think maybe one thing that maybe like it has improved, but there's still room for improvement is prenatal referrals for this population, whether it's to Katie, to the Mom's PRN line, to Dr. Sutter, to someone that, and the doulas out there, the community health workers that work with this population. If we know about them in the prenatal period and they come into the hospital and they have all these supports in place, it looks much different to the social workers that are going to see this family, that, you know, they have all these supports in place. You know, there is a safe place for the baby to go, rather than being reactive when they come in and they don't have any supports in place. As far as gaps, definitely it doesn't seem like there's enough housing out there for patients that are looking to get in housing. And it seems like a vicious cycle because they come in and then, you know, they don't have housing and they can't get housing. So housing insecurity is an issue. So, you know, DCYF has to get involved for that reason, but then there's no place for them to go. So it's just, it's unfortunate. And I think another like residential program where take, you know, more patients prenatally, and then maybe even for a longer period of time would be helpful for this population.
Yeah, I agree with both of those things. I think it is working well. I think definitely compared to years ago, there's a lot of new relationships. There's a lot more open communication. I think one of the things that I saw when I first came to Rhode Island was that people were working super hard in their own kind of silos, but they weren't necessarily talking to each other. And so a lot of work gets like duplicated, or people get confused because there's more than one person that can provide the same service. And I think there was also just a lot of lack of awareness of what each other were doing. And I think that has improved a lot. And so I'm glad everyone's here today too, to continue on that. One thing I will say that I think we're still missing out on, and I'm going to put a personal plug in for family medicine, is PCPs, right? Like, I think it's super important. We've found in the perinatal death review committee that a lot of deaths from overdose happened postpartum, right? Like months later. So that's kind of when a lot of our organizations maybe have like stepped back a little bit, or people have lost contact and like the attempts have stopped in reaching out, and people are really alone. So that's where we can be super helpful to you as family docs, right? We can take care of babies and moms together. We can just take care of the mom. We can take care of the boyfriend, their dad, whoever. And we still have lots of availability at all the area health centers. So keep us in mind. And if you ever need like a geographic PCP referral recommendation, I'm happy to provide that, because our trainees are all over the state, right? So we've got addiction aware and trained docs up in Woonsocket, down by Kent, all over. I think the other thing that's missing, like y'all have mentioned, is inpatient, not just for recovery services, but for like medical conversion to medications for opioid use disorder. That's something that when I was trained, that was my everyday, right? We had multiple patients on service at a time, getting on Suboxone at any weeks of pregnancy, and had institutional and financial support to do that work. I think, I don't want to offend anyone, but I think that is still lacking. And I know that we're all doing our best, and we have an extremely dysfunctional healthcare system, and it's really hard to do that. But I think we can do that, right? We have the educational knowledge in our doctors. We have all of us that care a lot about this work that can back it. And I do think we can get to a point where we are doing that more functionally. And then I think the third thing, like Erica mentioned, housing, right? Like a lot of times we will be so close to helping someone. We will have gotten them in recovery. They're hooked in with somebody for sustained recovery services, outpatient, like they have been through therapy. They've they've got all the medical part solved, but they don't have a house. And I think no one should have to be separated from their child because of a housing issue when they have done the hard work on all the other issues that are going on.
Yes. I have had a child that they were told that there was insufficient housing, and they had a room with a crib in it designated, and that was insufficient. And so I had a child out of the care of their mother for several weeks, all because they reported for not having housing. Now they had housing placement, but it wasn't sufficient. You know, they ended up at one of those long-term hotels or something like that was any better because like that's just a room too, really. Um, and so I'm gonna say ditto to all that, but I'm also gonna say like, what do you have for these people once they have their kids? Like, where are they supposed to go? Walk Rhode Island Mall, like with the Silver Sneaker Crew? Like, where are they supposed to go? Um, for all of us, like I'm always coming from a community lens, like. Yes, I'm also struggling like with this addiction or trying to work my way through, but this child will not stop running through the house and it's winter, right? And it's dark at 4 p.m and it's another 5 hours until bedtime. And so where are we sending these moms during this time with these kids that are running through? There's not a local, McDonald's and took out their plays. There's no more Burger King playgrounds. A lot of our malls or centers we go to, none of them have places for parents to bring their children. We don't have a lot of parenting support groups. The buildings are open until 5 p.m. Then all of a sudden everything shut down. Like people's lives don't go after 5. So I'm always going to bring it from the lenses of a community person as a new parent, never mind a new parent who is still struggling to stay sober or struggling to deal with mental health combined with substance use. What resources are we really building for parents to be supported? Because watching a 3-year-old run back and forth and fly off your furniture when you are trying not to drink is hard. Okay, that glass of wine is looking real good today, and it's only going to take one, and then 5 in, and you're running the bubble bath, and you don't know where your kid is. So these are things I want people to think of out of the box type solutions. Where are walking clubs, where are hiking clubs, where are gathering groups for people to come together to say, hey, also me too. And that's not just for substance use parents, but that's also a benefit to the child to run out all that energy. Where's the cooking classes? Who's teaching these people how to cook? They're just giving their kids boxed out foods. It's so multifaceted that I think that we just look at it and say, okay, this part of the hard work is done, but now this person has to raise this child with what resources in their community? Who's offering space? Who's showing up? Why do we not have a postpartum respite care program? Somebody come watch this kid for 4 hours so I can take a break or breathe, right? Because doulas are not babysitters. Let me be clear. Doulas are not babysitters. Doulas are not babysitters, nor are they nannies. And so where is the rest of the support, especially someone who has possibly burned bridges with their family and they want nothing to do with them and they've worked so hard and now they have this child and they have no family support or no friends. Because as cool as you are Monday through Friday, you my girl, at 6 o'clock and I cannot call you to come help hang out with me. I do not have anyone to come and support. And this also goes for dads too, because there are some single fathers out here, and they have a child that, is a child from substance use and the dad stayed and he's trying to figure out why this child keeps on trying to lick the walls. Like there's a lot that's out there and that we're not thinking about besides the 8 to 5. Life happens after 5 p.m. And what are we doing and how are we doing it? And that really needs to come from the community, not just institutions, but your agency. If the lights in your agency is on till 8 and 9 p.m., then you can run a program till 8 and 9 p.m. and find ways to fund it and find people to support it, whether that's church, whether that's membership, whether that's a couple plastic mats and somebody get some balls or something come together. Support people so that they can continue this journey because it is long and it is hard and they're fighting for their lives and they need people to support and cheer them on.
Can I just add one thing? I heard Ashley Decker speak, I think when she first came here as the new director of DCYF, and she said she really, wants to make the shift from mandatory reporting to mandatory supporting. And that really stuck with me. And I feel like DCYF has made a big shift towards being able to support families and not being punitive. They really want to try hard to really support families. Again, the time to do that is in the prenatal period before they come into the hospital. And really, the gap here is letting the patients know that they can come forward in pregnancy if they have a substance use disorder, and there are supports available for them. And I know there is a campaign through RIDOH for that, but if there's other mechanisms that anyone can think of to try to, undo decades of punitive action for substance use, welcome those thoughts.
I want to add something too. What's also not working is if we don't know about these families and then they just show up and deliver, like say they didn't have prenatal care, but they were getting substance use treatment somewhere, so somebody knew about them, but not like DCYF, which would have triggered a referral to me, or like community referrals. It's really hard to work with people that just show up and deliver. And most times it's an automatic ex parte, and I feel like it does them an injustice.
Totally. I think in response to that, Katie, and also what other people are saying, I think wearing my Project Weber Renew hat, I would be remiss to not talk about the gaps that we see. I see Sojo in the house, other people who are operating drop-in, no threshold services for folks. And, at PWR, we are seeing people who are not engaged in institutions often. They're using chaotically, they're homeless. And we have all these amazing services, but we do not have in the state of Rhode Island a low or no barrier place for pregnant people who are using drugs, who want help to go. I mean, I don't think that's a surprise to anyone, but I think it's a little bit the elephant in the room, at least from where I sit. Working with people who are using drugs, working with people who are having adverse reactions to the drug supply. I think we are making amazing progress, like Dr. Sutter was saying, as far as advocacy towards inpatient MOUD starts for people who are pregnant. What about our stimulant users? We have a lot of crack cocaine and even some methamphetamine users, in Rhode Island who are pregnant, and we don't have anything for them. And we aren't able to keep the lights on after 5 p.m. as a community-based organization. We do sometimes, you know what I mean? People go, some of them in here, I won't name names, above and beyond to, really meet people where they're at. But I think as far as care coordination, in that respect, it is really amazing. I mean, I think I work more closely with medical providers here in Rhode Island than I have anywhere else, because when people are ready and when they want help, we will drop everything, even as a non-clinical organization, to support people. And that means we're texting this person and calling that person. And is this person working tonight in the ED? Is this person, and I think we try to do more back channel things, but I think as far as, we hear everyone say engage prenatally, engage prenatally, engage prenatally, and that is not actually possible for everyone. So I just wanted to say that because I have to. Okay. So as we've discussed, pregnant and postpartum people who use drugs or have substance use disorder are involved in so many different systems: medical, behavioral health, addiction, DCYF, the courts, many other state systems. How does this impact your clients or patients, your relationships with them, and the work that you do?
I feel like it gets overwhelming fast to them. So I just kind of sit down and find like what's applicable to them and what they need. Prenatally, it will just be whatever they feel comfortable doing. But if in the event they do become DCYF open, I just stay there and advocate for them and try to help them get into any services for the DCYF recommendations to reunify as fast as possible.
I can say we are definitely stronger together. We all need each other. Anytime I connect with a patient and kind of see where they're at, it's like, all right, you connected with this person, you connected with this person. We in our different organizations, we can't do it all. We definitely need to work together to be able to support these patients. And they get confused on whose mission is, who is this person compared to this person. They do get confused. But if, we can work together and make it a seamless process and we can really communicate with the patient about, the supports that are in place and how everything works, it really becomes a protective factor for that patient. And it hopefully the point is to really create a pathway for them to be able to, have a healthy outcome in the end for mom and baby.
Yeah, I think I see patients get confused. I think doctors definitely get confused of all the different overlapping services out there and which ones are beneficial and which ones are like mandatory or not mandatory, and trying to help our patients sort of navigate all that when we're still trying to maintain trust with our patient just by ourselves. So I've worked with a couple of medical students and we've had inklings of making like a centralized place where all these things could be listed. And I still think that's a really good idea. If anybody wants to do that, email me and we should do that, so we can not overlap and so we can help best guide people.
This is a time where turn to your CHW and say thank you. Because these CHWs are rock stars at case management, navigation, and referral systems. They know which doctor they're working with, who's for what. Nope, you don't want to go there. You actually want to go there. I'm going to recommend you do this. This is what we're going to put in your safety plan. You don't need that in your safety plan. They're so good at what they do. So I'm going to take this time to just give a shout out to all the CHWs in the room. Please clap your hands for them.
And they'll go with you. They are
And they go with
to
so
appointments.
they build these relationships. They're with this patient at all times. And so, this isn't something that providers always have to do. This is where those relationships really come in because the expert in the room is generally the person who's with the patient. And so you have a CHW like, oh no, actually we did go to this appointment. Because sometimes the patient can get confused. Oh, which appointment did I go to? Oh, I'm not sure if I saw this doctor or no, I didn't see that doctor. And the CHW is like, yes, you did. Here's the notes right here. And you need that, right? Because there's so much in their mind. And so when you have these essential crucial workers in your systems, they're following the patient, they're able to go to all these places, not just in your institution, but they're able to be with their patients and maintain a reasonable caseload. Say it with me now, reasonable caseload. Then they're able to show up in a way that is really essential and help to streamline that process. So when they get on the phone with Erica, they could say, hey, Erica, I'm this HW working with Jennifer, and here's the resources that we have, and here's what we have for our safety plan. And we're connecting with you because we recently found out she's pregnant and X, Y, and Z, right? And here's her provider is Dr. Mary Beth Sutter and X, Y, and Z, and we'd love to be connected with Katie. So they can support all of that, but you cannot do that if you eliminate this workforce. Please support this workforce. Otherwise, you will be a provider trying to figure out what appointment, who's this doctor, what's their name. You don't have food. I don't understand. It becomes hard. And so, want to tell you that there are people who do this for a living. They're really amazing at it, and just want to make sure that we keep those people employed. We keep them in our community because they are crucial. Otherwise, a lot of us are going to be running around like chickens with our head cut off, trying to figure out 5 different providers, which therapists, as well as the social detriments of health outside of the 4 walls of medical care. We don't have food. Your landlord cut your lights off, or your right now the boiler's not working. Everyone's boiler is breaking, right? So your boiler's not working, the heat's not working. They didn't bring you a heating source, right? You have a visit with DCYF for reunification, and all of a sudden you don't have no heat, or the water got turned off, or the house got sold to somebody, and all those different things that don't always make it to the provider office, or they do, and the person is just a wreck, and you're like, okay, I got 30 minutes max before I'm already over to try to help this person to figure out their life with no CHW. That's crazy. Why would we do that?
100%. I also think, from my experience as a doula, that's really just time with someone. As doulas, we walk with people through the perinatal period, through this journey. And I think with this population, it is very overwhelming. We heard everyone say this for our folks. And I think really being able to put in that time with someone, building that trust. There's a lack of trust, there's fear, etc. We've talked about it a lot. putting in that time, because also that prenatal education, I think, especially with prenatal substance exposure, is really important. Talking about, what it's going to look like when the baby comes. There might be a NICU stay. You maybe are very likely will be discharged without your baby. And talking about all those things cannot happen with someone you do not have a relationship with, where there's not trust built. So I think that's what I'm thinking about listening to you, whether it's a CHW or a doula or a peer or anyone here, is just like really recognizing how much time it takes, and taking people to appointments. It's not going to work. You're going to have to sit in the waiting room with people, buy food, and I think, yeah, just really echoing what you're saying, Q.
Yeah, I want to highlight doulas have very limited time, where CHWs have a little bit more time. And then, yeah, you could always tag in family home visitors or, our CHW peer recovery coaches for this particular population. But just know that it's always nice to be able to do a warm handoff and know who's going to be in it for the long term with individuals. And making sure that from the beginning, yes, I absolutely want this doula at my birth. She's working with a CHW. Every doula should have a CHW that they call. I know I call my CHWs to come in, because I know they're going to need that long-term case management and navigation. And that is one thing that differentiates between a doula and a CHW. Doulas do not do case management. We are not your case management people. And so you want to make sure that when you have a client like this, that you've getting them everything that they need, but you're also getting them the appropriate people, so that they have that on their team.
Yeah, I think it's very true that the people that you're talking about make this happen. And I recall many circumstances where things would not have happened without that. Like, you are the ones sitting in triage buying chicken fingers to have people wait the terrible wait that they have to wait to get seen. Like, you are the ones finding somebody in a tent in January with a hemoglobin of 6 that's in the 3rd trimester. Like, I thank you so much. And whatever, like, if there's constructive things that we can do to help the CHW cause, please let us know what those things are so we can do them.
Yes.
Okay, just gonna do one more question and then open it up for Q&A for the last 10-ish minutes. But if there was one thing you would change about services in Rhode Island for this population, what would it be? And maybe to end on a positive note, like, what is your favorite part about this work?
I have to rethink my question.
It's 2 questions. I lied. It's fully 2
All right,
questions.
so the first part, my wish is, again, I know I'm repetitive, but mother-child houses, like, not as inpatient, intensive as Starbirth, but like a little more than Amos House. We have all these abandoned buildings, just convert one to this rooming house for women and children. And I've had a few cases where it wasn't the substance use, they had severe mental health on top of it, and there's literally nothing for that population, so it's a whole nother problem. They weren't stable enough mentally to go to even inpatient for 30 days. It was just a whole another thing. So then it made me think about people with strictly mental health, like, where do they even go?
There's nowhere to go.
Yeah, I know that's the problem. We definitely need more services for women that are pregnant. What do I love? I love when, I've worked with several people that have had several removals, TPRs, and like, maybe it's the 5th kid, the 6th kid that they did everything right. And then to see them take the baby home and parent for the first time is like the best feeling. And it makes all of the stress and hard work worth it.
My dream is to have a program where women can come forward without fear, either prenatally or prenatally optimally, but even in the postpartum period when they're struggling with their recovery, that they can come in without fear and get treatment, and stay there for as long as they need to, as long as they need to really be in a good place for themselves so they can take care of the babies. So keeping the patients and the babies together no matter what. And something I really love is I love seeing moms and babies together, and then seeing the development of the baby as well, when they come back later on for like the follow-up clinic or they come in to visit, and seeing how well patients do, with all the support that we provided them.
My wish is for a one-stop shop. So a place where people can come for prenatal care. They can come there afterwards for postpartum, for well baby care. We've got integrated behavioral health. We've got CHWs. We've got doulas. Everything they need in one place. So when they're dealing with the rest of the chaos all around them, they know that's one place. Ideally, they just show up and they can get what they need from whoever is available. And maybe it has a residence attached to it as well, and a step down residence and a working farm.
Yes.
It's my secret dream. The thing I like most about working with this population, and like it is hard, it is really hard, but I think the thing that I love most is seeing like that joy on the mom's face for the first time, and how proud they can be of, again, like some of the infant milestones, like when their baby is babbling for the first time, and just seeing that innocent joy that they have in celebrating their child, and knowing like that they have created that human and they're part of their life.
Mine is going to be multiple little community parenting hubs and support groups for all families, especially these families. And it's open 24/7 because y'all know Chuck E. Cheese closes at midnight. Um, and it's mad far, and there's no bus that travels out there. So it just would be nice if there were just places that people could really come to. Because I'm always going to be like, yeah, a regular parent got it hard, but a recovering substance user parent who is reunified, and this is what they wanted, they worked hard for, and then reality sets in, and it's a lot harder than they thought. And they just gonna need like a little bit of respite, somewhere that they can gather. You just bundle their kids up in their little footy pajamas, put them in the car, drive to this little spot that's in the same plaza as Shores or Stop and Shop, right? This is a normalized thing. And they go, and it's just like everybody else is there too, with all the same tired faces. And yeah, you could have CHWs and they're working with them or building out different plans, but just somewhere where their children can gather and they can just feel like a normal parent who's like, yo, today was really hard, but I'm so glad that this place is open that I can just come. And this is a place where like grandmothers can come and grandfathers can come, right? And you create this community of family support, of connection, of relationships, so that you don't feel as alone, because parenting can feel very lonely at times. Even with a two-parent family household, it just sometimes the weight feels lonely. And I think about this, including like grandparents or someone who's never gonna have kids, but they're the best like community neighborhood auntie or uncle in the world. Like a space for these people to be able to gather, to support, to say, don't worry, I got you. I'm here to help. I just need a moment. Maybe even throw some therapists in there. So in the middle of your breakdown and everything, you can kind of like snort, bubble cry. The one that's just like, and no one's judging you because they're like, oh my gosh, that was me last week. Like it was really rough, right? And then someone like gives you snacks. And you can get like a little sticker, right? Like I made it day 3. But really just somewhere that's going to support you in your empowerment as you're parenting, as you're navigating the space. And a place where the community's like, hey, I can't do a lot, but from 5 to 7, I can come to the community space and read books to your kids, so that, you can fill out an application or maybe go into one of the side rooms and do a Zoom for a new job interview, for a promotion, or get help filling out your FAFSA form because on top of everything, you decide to go back to college so you can make more money. I think we just need more community spaces that are open and available to people. And that part we're all crucially missing because we no longer have big extended nuclear families anymore. Everyone is working. People are like 69, still work, got full-time jobs and sometimes part-time jobs. And so it's really hard to pull in a community where everyone has to work and we're all struggling. And so it needs to be all of us, not just mom and baby, but dad and baby, birthing person and baby, grandpa and baby, grandma and baby. And some people are removed from their families because they're not connected. And so they need to create chosen families. And you might be a chosen family member. And so things like that can just organically happen in these spaces, but they can't happen if we don't create them. And what's working? What do I love? I love when the people come back, or even if they don't come back, but you hear about their story on how everything worked out in their favor. You know, it kind of gives you a little boost of like, I'm so happy they made it. Like, I'm so proud of them, right? Like, it's just this inner joy. Like, their success brings you happiness. And even for the ones, it's just like, you want to know what? They tried, you know, and maybe they'll get an opportunity to try again. And so just really trying to keep the optimism going, and being happy, you know, cheering for the successes and being like every delay is not, you know, every denial is not is just a delay. What is it? It's your it's a setback is just a set up for a comeback, and kind of like having that mentality, because sometimes that's just our everyday lives as regular people.
Thank you. Let's give a round of applause to our amazing panelists. We have time for some questions, couple questions in the back. You can.
Here mention transportation in the addiction world. We have clients having a lot of difficulty get to addiction facilities. Love trying to have things located close to these folks in the community, but I would think that would be one of your big.
That's those CHWs driving everybody in their cars around.
And that's what I was gonna say.
Peers. Was your question just like, yeah, more talking about it?
I can
Totally.
definitely say that our CHWs and the peer, definitely Katie, they are so good about picking patients up where they are and bringing them where they need to go. That's why when I said that we really need to like work together, we need to stick together and we're stronger together.
And even women and infant social workers over at OGCC, they'll Uber them to and from appointments if need be. And Dr. Sutter's office does so.
Yeah. I am wondering, what about all those church vans sitting in those parking lots every Sunday? The church you go to have a multi 18 passenger van? I drive past a lot of vans sitting in parking lots, and I always wonder if someone called them up and was like, hey, Monday through Thursday, when you're not running Bible study or Sunday service, would you be willing to use your van as a way to kind of transport? I think a lot of what we want needs to be creative and out of the box, right? Because Uncle Ripta is leaving you on the side of the road. I was trying to navigate my high schooler to take the Ripta, and I gave her some change, and she was like, "We don't use money." I was like, "Oh my gosh." You don't use money. She's like, you have to get a card, you have to load it. I was like, oh no. So I can never, I can't imagine people who all they have is a pocket full of change, but for some reason can't get on a Repto, or they don't have a card, or they don't have a bank account to load the card to be able to navigate, right? Like, where are the resources? Yes, Providence is small, and for the most part, you can walk anywhere within 4 to 5 hours from one end to the other. But why are we asking that of our community? What other resources? Think outside the box. Who can show up? How many agencies have Uber Health accounts that they're willing to be like, I'll share my Uber Health account? And reminder, we have 5 birthing hospitals in the state of Rhode Island, right? We have Kent, we have Newport, we have Women and Infants, we have Landmark, and we have South County. So most of the time, we're only speaking about the one that's in Providence. But what about all of the other hospitals? They have vans. What are their programs looking like? Who's here from Newport or South County that can speak about what program is happening out there? Because these people are everywhere. They're not all living in Providence, I promise you that. These are substance users unidentified. They live in Barrington. They live in Wickford. And they're able to disguise it because of their wealth. And so no one notices, but also where are their resources at for them to go? And so yes, they may have transportation to get to and from, but they might not have the resources as diversified as Providence. But let's all keep it real. Anything out of 20 minutes is a day trip. So no one is coming from Wickford to Providence for care. And so we need to think of these type of things of how can we create these hubs in each community? What does transportation look? Can you partner where your local Baptist church or Pentecostal church or non-denominational church to say, hey, I was recently at this conference and they said that they would love if they can get some transportation services. Is this something you would be willing to work with them on so that they can get families to their appointments, so that they can get some type of help?
Any other questions? Maybe also from someone who's not represented up here. I'd encourage you all to ask a question.
One thing I just wanted to pick your brain about is a couple years ago, Eastman House closed, and like I feel like there was no plan after that. So now there's a huge loss of residential for women in general. But that building still exists, and I'm wondering if there's any work to like open a respite or to fill that gap.
Is CCH supposed to get that building? Yeah.
So Victor was gonna get it, but it didn't, something fell through with BHDDH, but yes, I agree. Yeah, I think Victor was supposed to open it and convert it into something and it never went through. I don't know what happened, but I hope they do reopen it. Be perfect for mothers and babies.
So just a quick comment, I'm sorry. What, all the people in this room work with this population, is that right? So a lot of the people who are not in the room, where's their education coming so that they can be the person that makes the referral to the youth? So if they're going through the ER in a different hospital where no one's seeing them for this, or they've got the stigma of being identified as a person with a substance use problem, even if they're not pregnant, they're not getting treated the way they should be treated because we still have medical staff, nursing staff, social work staff who are highly biased against this population, even if they're not pregnant. So how do we do this kind of education to people that don't know anything? Or should know something,
Yes.
but I don't know. I've done some trainings for nurses because the Department of Health says all nurses have to have 2 hours of education in addictions to get their license renewed. After I do some of those trainings and I talk about the neurobiology of the brain and why, the nurse will say in the post-survey, I didn't know that. That wasn't taught to me in nursing school. So next time I have a patient in the ER, I think I'm going to treat him differently. Wow. Impressive, right? So we need to think of how to teach those people who don't know anything.
I think we should have you go out to all the nursing schools. Get your coin, okay? It's a season to get a bag. And go to, because this is vital information. Start in the nursing schools, have it be a requirement. Because I know they're doing a lot of community efforts, but this is something that should be URI, Salve Regina, CCRI. And it's not just nursing. So everyone within the medical profession. But I also think that this is something that maybe we can do an evaluation survey, RIDOH, in the room to evaluate whether or not any and all of these interactions within community settings, especially medical settings, or even social service agencies outside of everyone here in the room, where are you at? Really doing a landscape analysis to say, how can we evaluate and how can we do better? I also think you should offer your training online, so that everyone can get your 2 hours, whether they're a nurse or not.
I can add that the Rhode Island Maternal Resource Network does an echo series that anyone can join. They will have 8 sessions in 2026. So be on the lookout for that, and anyone can join those trainings, and it's around maternal mental health.
We're not you. We're going to make that.
That's what we're trying to do.
Yeah.
Spread the word.
And we did do a series before, which is recorded and it's online.
And I'm part of the planning committee for that. So we haven't like planned it fully out. So if there are those of you in the room that would like to speak on it, we would love to hear from you too for that, because I think it's more powerful when we have representation from all our organizations.
You have a question?
So I have a question. With the population that we're dealing with comes a lot of bias. So how would we be able to identify what is protocol and procedure and policing?
So, all right, I would say that it's not my job to like call out people's biases.
Right.
But I've noticed like being there and supporting them, I feel like minimizes the biasness and discrimination towards these people. I had one client, several clients, I should say. It happens all the time. Like I'll go there with them and they're so nice. I'm like, oh my God, they're great. But then like she goes by herself and then I get feedback that they treated her terrible. So it's just trying to be there as much as possible.
I remember when I first started doing doula work for this population that one of the hospital administrators in Philly was hearing our feedback about what we were observing and experiencing. And they were like, oh my gosh, we've never had eyes in the room before. And I thought that was so interesting because patients have eyes. But what it makes me think about is like whatever is going on at your institution across interdisciplinary teams, this work is hard. And in my ideal world, not being, in a hospital setting, there would be time and space for facilitated conversation between disciplines to talk about policy and practice, because those things are different from each other. And so I think it's a subjective thing to some extent if someone is following a policy or a protocol, or if it feels like policing, but that's a problem. And so there needs to be a way for people to communicate with one another with, respectfully. And so, yeah, call me. I can.
I think one of the things is like I know DCYF has a template that that design. I think actually Mary Beth shared it with me as far as like what is the protocol when it comes to substance use. I'm really big on report them. I love reporting me a trash provider. I promise you. I will have you investigated because if you are violent to the community, you don't deserve to have a license. And so I think we really need to see that sometimes the system doesn't hold the people who do the most violence accountable. And sometimes we need to empower the community to hold them accountable. So I'm really good for popping up an investigation at RIDOH. Definitely ask for a facilitation investigation. Definitely contact your insurance company and let them know you are not satisfied with your care. I was treated this way by this provider. This is their name. This is the time and the date that I went to the hospital, and have someone else do the legwork. But a lot of the time is you have repeat offenders because they're not being held accountable. No one's saying anything to them. You're going to go to the hospital. You're going to talk to patient care experience. They're going to sit in a meeting and tell someone, no, file a complaint against their licensure. I was discriminated against. This has promoted harm. This has set me back in my progress. This has X, Y, and Z. When someone's livelihood is put on the line, and that is right, the care that we're doing. In this care, it is someone's life that we are working with. Then I'm for tit for tat. If you're gonna treat me like trash, you're gonna fail it. You're not gonna get a paycheck. You're gonna come under review. They're gonna do an investigation on you, because we cannot have people giving their whole heart for this. It makes everyone look bad. That one bad social worker makes all the rest of the social workers look bad. That one violent provider who is promoting obstetric violence but not using proper protocol, that makes it so that other people think, oh, those providers at that entire practice gets blacklisted because there's one particular provider that the community knows, oh, this person's going to do this without your consent. This person's going to do X, Y, and Z. And so it's really about, that self-advocacy, that self-empowerment to say, was you treated this way? Here's some ways that you can, handle that situation. You want to reinstitute some type of dignity and integrity back to the person who was so violently harmed. And violence doesn't always have to be someone physically. It could be the emotional abuse, the mental harm that you do to someone, that if you don't have Katie going with you, you're like, wow, Katie talks so good about that provider, but like, they really made me feel horrible. Like they made me feel like I was dumb, that I didn't know what I was talking about. They made me feel like I was drug seeking or I was abusing, that type of stuff. It sits with you, it ruminates in your head, and then it starts to make you think that maybe I am this person, right? When you're down and in a dark place, maybe I am this person. Or they police you. They're going to call social services. Social services comes into the room. They come in with a nurse and do the whole arm thing like this while they talk to you. So I heard that there was a problem in here. Like, don't do that to people. So yeah, get their name, get first, last name, and report them. And that's the only way we're going to see a culture shift, because sometimes the culture of harm is embedded so deeply into an institution that as much as the administration, as much as the good providers are doing their best, they can't make change, right? Like these unions ain't nothing to mess with. And so sometimes it has to come from the outside, or you just give them a bad Google review.
Thank you.
I just have a couple of thoughts about that too. Sorry, from the medical perspective. I think we are not taught this in med school. Like, no one taught me this in med school. We have held several panels for the med students, like you were at one, and Corin talks to the med students too. They eat it up. Like, those panels are really, really, really well attended. Like, they want to learn. We should have one every 6 months, right? Who wants to come do one? I think let's go. When I first came here too, like every state handles this stuff differently, right? Like I remember the first time someone put a PRE in front of me and I was like, what is this? And I'm not signing it. And do I have to sign this? And yeah, I was told I had to sign it, and come to have like many conversations later with some of the judges, with DCYF themselves. That was part of the inspiration for the working group, right? Because our PEDS faculty and family medicine faculty were kind of like, this just doesn't feel right, right? Like we're signing these pieces of paper, like this is a direct communication to the judge, and we feel like, our like medical license is like being used in a way that's really uncomfortable for us. And so I do think that again was like a matter of like opening up that communication. So everybody's sort of on the same page about what's the purpose of this piece of paper? Like, what are we really using this for? And like, let's use it for a good reason. Let's not use it for violence, right? Let's talk about how if there is a hold, you're asking me to put a hold, that means the stopping of rooming in. Like, why does that have to happen? Let's talk about that not happening. Let's talk about prenatal care before, so that we can stop, prevention of rooming in, because we know how good that is for babies in withdrawal. So I think, keeping those communication lines open, like you said, cultural change is hard. It is really, really hard. And it's something that I have been thinking about for 6 years in the institution where I may work. But I'm still trying. And I think we put these trainings together, right? We have lots of different people in those trainings. We record them, we make them mandatory. We have in-person representation where people are talking to you face to face, right? That's a much different conversation than something happening behind closed doors with a piece of paper that's anonymous.
So that's all that we have time for, but I do just want to say that I think for me personally, a takeaway from this conversation, but also from the whole day, is that we need to talk to each other more. I think we can work in silos, but we also need to understand everyone else's perspectives better. And so here's a plug. We do meet monthly, the Perinatal Substance Use Task Force, and that can be a place for us to have some of these conversations, because this work is complicated. It's constantly changing for all the factors we've discussed. And we can talk about patient care and how to improve that and how to create new services, but we need to be in relationship with one another, and we need to communicate with one another about what we're experiencing and what we need from one another so that we can provide better care. So that is my parting wish for all of us, and just want to say a big, big, big thank you to you all, especially to you four. So thank you.